Ian. So we all have our respective delegates, judges, and medical students on live. On this gorgeous evening, with this exciting minds, I would like to welcome you all to this magnificent event in the view of commemorating Adrenergix 2.0 MEDINERVE case presentation. We would like to extend our sincere thanks to our national team, our state advisory team, our state team, and also to all the participants. The groundworks of this program was initiated long ago and now we are in the version of 2.0 Podium of Learning. Adrenergix 2.0 is the most awaited pan-India academic event where the organizing committee is conducting around 10 online events from September 30th, 2023 to 9th October 2023. We are delighted to invite you to our clinical case presentation event. This event is a hub of knowledge, collaboration, and professional growth designed to enhance clinical expertise and foster a deeper understanding of challenging medical scenarios. This event is the perfect stage to showcase your diagnostic powers, gain knowledge, and contribute to the collective learning in the healthcare community. We are proud to announce that our team have worked tirelessly to make this event an awesome one. Together, let's embrace the art and science of medicine, broaden our knowledge, and strive for excellence in patient care. We look forward to welcoming you to this enriching and intellectually stimulating event. It gives me immense pleasure to welcome our judge, Dr. V. Dharani Ma'am, Assistant Professor in the Department of OG, KIMS. Ma'am has done her MBBS at Government Shankarpat Medical College, Tamil Nadu and MS, Government Keelpark Medical College, Tamil Nadu and obtained DNB OG degree in the year 2021. Ma'am actively involved in UG and PG training and completed basic course in biomedical research and reversed basic course workshop and actively participated in several national and international OG conferences. Ma'am has organized yearly emergency workshops and guest lectures and CME. Currently, Ma'am is doing a cross-sectional study on anemia in pregnancy and its associated risk factors. I am feeling proud to welcome Ma'am, the groundbreaker as the judge for OG case presentation. Ma'am, kindly share a few words.
Hello everyone. Thank you Pavitra for the warm welcome, and I feel so happy to be a part of your academic event, and I'm actively looking forward to what all the young minds here have to say. So thank you.
Thank you, Ma'am. It gives me immense pleasure to welcome our guest, Dr. B. Vignesh Sir, Senior Resident at MMC. Sir has done his MBBS at Government Vellore Medical College, Tamil Nadu Dr. MGR University, and MS Surgery at Madras Medical College, Tamil Nadu Dr. MGR University. Sir has published numerous papers, posters, and videos in various conferences like ASICON Mumbai. SAN has been participated in conducting and organizing various enrichment programs. SAN has organized programs for World Health Day, World AIDS Day, and many other. Several of his clinical works have been published in indus journals. SAN is known for his vibrant knowledge, charisma, and grandiloquence. I am extremely honored to welcome Sir, the trailblazer, as the judge of this great event. Sir, kindly share a few words.
Hello, people. I'm Dr. Vignesh. I got a chance to go through your case papers, and they are very interesting, and I can't wait to have a discussion with you about it. All the best. Like, don't feel any pressure. Just be your natural self and do your best. All the best.
Thank you, sir. With no further delay, let's quickly start off. I request every other participant to log out. So Hrithik Selva will be starting this event.
Hello, good evening. Am I audible?
Yeah, you're audible.
Thank you. So, should I start my presentation?
Yes, please.
Yeah, thank you. Good evening, respected judges. I'm Ritik Sawla from Grand Medical College, Mumbai. Today, I'll be presenting a case on atraumatic gas gangrene in synchronous colonic malignancy by Clostridium septicum. A 44-year-old male patient came with complaints of pain in the abdomen for 3 months and passage of black-colored stools for a week. There was a significant history of weight loss and an addiction history of smoking of 10 packs per year. There was no history of fever, no history of hematemesis or blood in stools, no history of jaundice and itching, cough, hemoptysis, back pain, headaches, and seizures. After 20 days of admission, the patient developed spontaneous sudden onset right lower limb gas gangrene. The skin was mottled as seen in the photo. The discharge was foul smelling and crepitus was also present. Past history: the patient did not have any comorbidities like diabetes, hypertension, TB, or asthma. There was no past history of any surgery. Personal history: sleep and bladder was unaltered. Appetite was decreased. Smoking history: 10 packs per year. There were no known allergies, and family history was non-contributory. The general examination was unremarkable. Patient consent was taken before the examination. On inspection, abdomen was flat, umbilicus was central and inverted. All the quadrants moved equally with respiration. There was no generalized or localized fullness. Skin over the abdomen was normal. There were no scars or sinuses seen. No dilated veins were present. External genitalia and back was normal. On palpation, inspective findings were confirmed. There was no tenderness, no local rise in temperature. On palpation, an ill-defined firm lump was palpable at the right iliac fossa. Sorry. It was hard in consistency and immovable. There was no organomegaly and no enlarged lymph nodes. On percussion, there was dullness over the lump, and there were no signs of free fluid in the abdomen. Investigations: contrast enhanced CT of abdomen and was done, and colonoscopy was also done, which suggested two separate lesions at the ascending colon and the sigmoid colon. Histopathological examination confirmed the diagnosis of adenocarcinoma. Microscopic examination of the foul-smelling secretion suggested of Clostridium septicum. In the image, the upper two images shows ascending colon CCT image and colonoscopy image, and the lower two images show CCT and colonoscopy of the sigmoid colon. The growth is highlighted in a red circle. The differential diagnoses include appendicular lump, ileocecal TB, carcinoma cecum or ascending colon, psoas abscess, amoeboma, undecentered kidney, and testicular tumor. Management: an emergency right below knee amputation was performed. Digital subtraction angiography of bilateral lower limbs was done post amputation, which was suggestive of extensive atherosclerosis of both the lower limbs. Bilateral aortoplasty and stenting was performed for the same. Definitive management: later the patient underwent total colectomy with ileorectal anastomosis. Two hard lesions was found at ascending colon and the sigmoid colon. Histopathology suggested well-differentiated adenocarcinoma. TNM staging showed PT3, N0, M0. It was stage 3. Discussion: the overall incidence of synchronous colorectal cancer is 2.3 to 12 to 12.4%. Clostridium septicum is known to cause atraumatic myonecrosis in such malignancies. The occurrence is rare but highly fulminant. Clostridium septicum are more aerotolerant and associated with distant atraumatic myonecrosis, which is most likely due to the hematogenous CD. Conditions precipitating hypoxia, such as chronic inflammation, chronic ischemic conditions like atherosclerosis, as in our patient, anaerobic glycolysis by tumor cells are the risk factors. The treatment is always aggressive since the average mortality is greater than 60%, especially if the treatment is not started soon. Ultimately, the patient needs aggressive resection of the single malignancy of the colon. So to conclude, infection with Clostridium septicum, although rare, can lead to fatal outcomes and a poor prognosis, owing to its highly virulent and aggressive nature. This warrants early identification and initiation of the treatment with an aim to reduce the mortality. Patients who present with underlying colonic malignancy and signs of infection or sepsis should have a high degree of suspicion that they might be having a Clostridium septicum infection. These are the references. Thank you.
Hello, Ritik. That was a nice presentation. Uh, Going back to the history, like you told me, the patient had abdomen pain for 3 months, right? Uh, like and the patient, what are the positive past histories? Does the patient has any like smoking habits? Like is the
Yes,
patient
sir. There
smoking?
was a positive smoking history of 10 pack years.
10 packets of that.
Yes.
Do you think abdomen pain is a very common symptom for a case of malignancy?
Uh, so for abdominal pain, there are a lot of DDs. So this was from 3 to 4 months, and more recent ones like appendicitis, polycystic gallbladder diseases, and all inflammatory. Those are more
Okay.
common, but they are acute in presentation.
Okay. Can you go back to the first slide, please?
For the first,
First slide, yeah.
yeah, yes, this one, sir.
Yeah, this. You told me there is history of passage of black fluids too. Like, what is that for?
Melina, sir.
Okay. Uh, so let's say like this patient, since the patient has a history of 10 back years, uh, I'm suspecting that abdomen pain might be because of atherosclerosis of the mesenteric process. If I'm suspecting that, what specific history will I ask with regards to abdomen pain?
So can you repeat the question?
Let's say like I'm assuming this abdomen pain. I have a suspicion that this pain, abdomen pain, might be because of uh, a mesenteric atherosclerosis of the superior and inferior mesenteric arteries, and the black colored stools might be because of necrosis that happens because of that, and there's melena because of that. What history will help me like come to the diagnosis?
So in this pain in the left upper quadrant would be suggestive of splenic flexure involvement, which is a watershed area, and most likely it is associated with ischemic colitis,
Like,
like atherosclerosis.
yeah, like the common symptom of any atherosclerotic in an arterial mesenteric artery is postprandial pain. If
Okay.
there's pain after, specifically after, and if there's abdominal pain all the time, but it increases after, that's like very specific for atherosclerotic disease of the abdominal vasculature. And if there's any melena in a patient that has like chronic history of uh, smoking, then that should be a history that we should always ask. And why I'm saying that is like this patient also had like bilateral atherosclerotic disease below lung. So this patient definitely has a vascular pathology like throughout his body. So we should also suspect similar complaint in abdomen also.
Yes.
Sir, going to gas gangrene, like why do you say it's gas gangrene? Like why can't it be a necrotizing fasciitis?
Sir, first of all, the clinical presentation of the gas gangrene, the skin was totally mottled, as seen in the picture. Also, crepitus was heard, which is pointing
Was third?
towards gas. What's that?
Third? Crevitis was third or felt?
It's heard, like bursting of gas bubbles.
Okay, how will you hear it?
What's that?
Like how do you hear the crepitus? Like see, crepitus is like a palpatory something. It's not a auscultatory or like it's something that you feel. Like it's the feeling of something like breaking when you. It's the feeling of bubbles breaking when you
Bubbles.
palpate.
Yeah.
Yeah. Okay, go on.
Yes.
Yeah, like sorry. Okay, going on to the management. Like you said, you did a amputation for the gas gangrene. What kind of amputation did you do?
So it was since the right lower limb was involved, so below knee amputation.
Hmm. Okay. Do you do an amputation? Like, let's say, like I have a diabetic foot for which I'm doing an amputation, and I have a uh, gas gangrene of the foot forwards and the amputation. Do you think I'll do the same kind of amputation for both the patients, or will there be any difference?
For the gas gangrene, it is a little bit more above. For diabetic foot, it can be a little lower, like because it does not directly spread. This can be the infection can spread through the blood vessels.
Yeah, that's true. Like some gas gangrene can ascend very rapidly, and that is why we need to do an early amputation. But point I was looking for is you need to leave the flaps open, can't close the flap. In a gas gangrene, you should always do a guillotine amputation. You're not supposed to do a posterior flap closure of the arm.
Yeah.
So moving on to the malignancy part. Let's say like there's a case where you do a sigmoidoscopy and like this patient had a lesion in the sigmoid colon, right? Let's say like you did a sigmoidoscopy and you found a lesion there. What's your next step?
So, stigmatoscopy assisted biopsy can be taken, which can be sent for histopathological examination. Also, it should be correlated with the patient presentation, like clinical examination and patient history, to come to a diagnosis.
Yeah, Ritika. Like, let's say like there's another patient, a totally different patient. You do a sigmoidoscopy and you see a lesion. You find after you always find a sigmoid lesion, you should always follow that up with a colonoscopy. Why? Why do you always need to do a colonoscopy in a patient in which you found a lesion?
Because there because there can be multiple lesions
Yeah, yeah.
occurring. Like also the family members, like especially the first degree relatives, should be screened.
Okay. Okay. Yeah, that is what I was expecting. You know? Like,
And the first degree relative should be screened 10 years prior to the age of diagnosis of the patient
okay. Okay.
for screening.
Uh, what do you the reason why you do colonoscopy in all cases of a sigmoid lesion or even a sigmoid polyp is the incidence of synchronous lesions is very high in colonic malignancy. So always do a colonoscopy. Uh, let's like do you think a left-sided colon malignancy and right-sided colon malignancy will present the same way, or do they have like different ways of presenting?
Um, for the left side malignancy, there can be more of obstruction features,
Okay.
and for the right sided, there can be bleeding and all. So melena can be the major.
Okay. Good. Good. That's right. Do you think there's any difference in the pathogenesis? Can you tell me about the difference? Is there any difference between the pathogenesis of the right and the left side of colonic malignancy? In the sense of the mutations that happen in both the right and the left. Are you familiar with this?
Uh,
Oh, that's
so
okay.
I'm not sure. There
It's
can
okay.
be
Okay. It's very like you're doing really good. That's why I'm going this far. You've answered well.
KRAS
Let's see. Like,
mutations can be seen.
yeah. Okay. Let's say what is the difference between uh, APR and LAR?
Can you repeat, sir?
What is the difference between a low anterior resection and the abdominal perineal resection?
Uh, so in low perineal resection, the descending colon, the sigmoid colon is removed, and there is anastomosis done till the rectum,
Okay.
like till the clear anal anastomosis.
Okay. Right. What is APR? What is abdominal perineal resection?
Uh, so you're talking about the
It's
malignancy in
a,
the ascending colon.
no, no. It's a surgery that we do for rectosigmoid lesions. Right? Like both LAR and APR are surgeries that we do for rectosigmoid lesions. Okay, like abdominal perineal resection is the surgery where you remove the entire anal canal with the sigmoid and like part to the sigmoid. Like, if you do that, the patient will have a permanent colostomy after the surgery. But if you do a lower anterior resection, the patient can retain the natural anal orifice.
Okay, yeah, right. The stoma will be assigned to the.
Yeah. Yeah, thank you, Rachel. Like, you did really well.
Thank you, sir. I can leave the meeting, right?
Yeah, who's going to present next?
Okay, thank you so much, sir.
Okay.
Hello.
Hello, Roshan.
Hello, sir.
Yeah, Roshan, what is the case you're going to present?
I'm gonna present a case. I'll move on with my case somewhere. Okay.
Okay.
Yeah. I'll see. Can you see my screen, sir?
Yeah, yeah.
Right. So yeah, shall I start, sir?
Yeah.
Yeah, so here's an interesting case that I'd like to present here. So there is only so much that we know about a lot of things, and there are a lot of things that we don't know about so many things. So here's this case which we knew so many things, but there was no as well. So we'll move to the case right away. It was a 67-year-old female who was from Valpare. She came with chief complaints of altered sensory
Roshan,
days.
just a minute. Just a minute, Roshan. Like, the screen I'm seeing, it doesn't show your PPT.
Oh, okay.
Yeah.
And now, sir,
It's showing something else. Like, it's showing some landing page of some website.
uh, okay. Now, sir.
Yeah.
Yeah. So yeah, it's a 67-year-old female who presented with the chief complaints of altered sensorium for the past 2 days, and it was associated with nausea and vomiting as well. And she was a known case of diabetes and hypertension for the past 4 years, and she's been on treatment for the same. And others were negative history. She did not have a history of loss of weight and appetite. On examination, the patient was found to be drowsy. She spoke few words, but she was able to look well today. So we came to a GCS score of about 11, and the pupils were 3 millimeters and was sluggishly responsive to light. And she was able to move all the limbs with no paucity. And the reflexes and the tone of the patient was normal in all the limbs, and other tests were not able to be performed due to her altered mental status. So we proceeded on with the head CT. Uh, and on ECT brain, we were able to see a hyperdense lesion measuring about 3.5 into 2.6 into 2.6 centimeters, noted in the right frontal region, which was associated with a surrounding edema. So with this, proceeded on with an MRI, plain MRI, which was diffusion weighted. And here we can see the lesion in diffusion weighted MRI, and the diffusion was restricted. On susceptibility weighted MRI, we were able to see blooming, suggesting that it's a mass adenoma. So based on the plain MRI findings, we proceeded on with contrast MRI. On contrast MRI, we were able to see a well-differentiated contrast enhancing lesion in the genu of the corpus callosum on the right side, and it was compressing the front of the right ventricle, right lateral ventricle, as well as the third ventricle. So this is the finding we had on T1 contrast, and on T2 contrast, we were able to see a heterointense lesion. A heterointense lesion with perimetrial edema was present in the same location as I told before, the base of the extending up to the genu of the corpus callosum, also compressing the right lateral ventricle as well as the third ventricle. With this, we also proceeded on with an MR spectroscopy. Here we can see the elevated N-acetylcysteine. The choline was also elevated as well as the creatinine, suggesting that it is likely to be a hypermetabolic state, a space occupying lesion with a hypermetabolic state, likely with an impression of a tumor. So we managed the patient by doing a right frontal craniotomy and excision of the space occupying lesion, and the subtotal excision of the space occupying lesion was done along with the placement of a right external ventricular drainage. And the part which I was telling earlier, the known yet unknown, there was so much that we knew about this case, and there was so much that we didn't know about this case, which we encountered intraoperatively, where we can see a blackish firm, highly vascular lesion with intraventricular extension. This was the intraoperative findings that we had. So we went on with a histopathological examination, and as expected, since we had a blackish lesion, it showed pleomorphic cells with vesicular nuclei and prominent nucleoli. And there were areas of necrosis and hemorrhage as well. We can clearly see the melanin pigment on 10x microscopy and 40x microscopy. Within the cytoplasm, we are able to appreciate the melanin, so likely indicating that it's a melanoma. We had the impression of a glial tumor earlier. So we wanted to exclude glial tumor, for which we did a GFAP stain, and the tumor was negative for GFAP, and it was just positive in the glial components alone. So likely ruling out all the meningiomas and all. And to definitively confirm that this is a melanoma, we had to do immunohistochemical studies, and it came out to be positive for melon A as well as S100. So the immunohistochemistry favored a malignant melanoma of the right frontobasal region. So post-operatively, this patient improved several fold, and we can see a little bit of a perilesional edema. And apart from that, the post-operative contrast CT came out to be normal. And the important crux of this discussion is that we were able to see that there is melanoma of the brain. So we have to evaluate the patient further. So we went on with a thorough head to foot examination. Interesting part is there was no hyperpigmented patches or nodules anywhere in the body. And there were depigmented patches in the soles, likely suggesting vitiligo vulgaris as said by the dermatologist. And we also had to, find where the primary is coming from. We did a CT abdomen as well as thorax. It came out to be normal. So this was the post-operative evaluation. So the main discussion of my case report here is that the melanoma here, the melanoma of the brain, we couldn't find the primary of this lesion. So it's a melanoma of unknown primary, and 97% of all the melanomas that you're dealing with has a primary, which is most often the skin that's involved. And 3% of the cases, we are not able to assess where the melanoma is coming from. So what about another close differential, not rather differential, a close diagnosis that we could give is primary intracranial melanomas, which actually constitute about 1% of all melanomas and about 0.07% of the brain tumors. Such a rare entity, but that happens to be the limitation of my case report here, is because we were not able to do a PET scan due to the financial constraints of the patient. So with whatever information that we have here is that it's a melanoma of unknown primary. As I told earlier in my first slide, it's known yet unknown. Only so much that we knew about the tumor, and we happened to unravel so many unknown things in the intraoperatively, which was the melanoma. And here we found melanoma, but we were not able to find the primary. So yet it is a known, but yet unknown. Yeah, that's the case that I'm here to present. Thank you.
You presented well, Roshan. When you did a thorough head-to-foot examination, did you find any, what are you looking for when you did a head-to-foot examination, right? Like what were you looking for?
Sir, since we found melanoma in the brain, it's likely to be a metastatic melanoma. So,
Okay.
if it is a metastatic melanoma, we are suspecting hyperpigmented patches in the body. So, these hyperpigmented patches, as per malignant melanoma, we have the ABCD lesion, where we have asymmetry of the lesion. The borders are usually uneven. There is a color change. There is depth. The depth of lesion as well as the elevation of the hyperpigmented patches.
Okay. Do you only look for hyperpigmented patches while looking for lesion?
No, sir. Even there is amelanocytic melanoma where there could be hyperpigmented patches as well. That
Okay.
was a suspicion we had when we saw the vitiligo vulgaris. We did discuss with the dermatologist. The dermatologist clearly said it is vitiligo.
Okay. You just told me about the ABCD of
Yes.
where where does the melanoma rise?
Melanoma usually arises intraepithelially, sir, and
Okay.
due to the melanocytes that are present in the stratum granulosum, and then proceeds further, since it's an important thing.
In what layer of the epidermis does the melanoma arise from? In what layer basically has the melanocytes?
The
You know,
stratum granulosum, sir.
right? Uh, let's say like you find a melanoma. You find a melanoma. Let's say not in this case. You find a different case where you are able to make a lesion. It's hyperpigmented. Uh, like what you just told me about the pre-malignant features, right? The features of the malignancy. What are the pre-malignant lesions of melanoma?
Uh, so all the moles have a potency to develop melanoma.
All moles.
Not, no, sir.
What what are the kinds of moles that are malignant? What are the kinds of moles that are not malignant? What are the
Moles,
types of yeah?
moles that are acquired in future, most
Okay.
congenital moles involving the body are not having the potency to develop melanoma. Whereas moles that have predisposition to involve the face have a potency to develop melanomas.
Are you familiar with the term called junctional mole?
Sure.
Do you know what a junctional mole is?
Yes, sir. It's arising from the junction between two. There's a transition zone between the junction usually the mole arises. So in melanoma involving the GI tract, most commonly involves the anal region. So in anal region, there is a transition of epithelium from stratified squamous to columnar epithelium. At the junction, the melanoma arises.
What are the types of melanoma?
So there is pigmented type, actual lentiginous type, desmocytic melanoma, amelanocytic melanoma, and
Right. Uh, let's say like you find a lesion. What is the next step? And like proceeding with the management.
since if I'm in my case, if I find a lesion, a hyperpigmented patch, it straight away goes to stage 4 of melanoma since there is distant metastasis. So I would be proceeding on with palliative chemotherapy, sir. Palliative care for the patient.
Okay, let's say like you find a different patient. That
Okay.
patient doesn't have a brain. But if that patient just has a lesion,
Okay, sir.
what's your next step?
So I will be my first approach will be surgery, sir. I will be giving a margin of be it 2 centimeter or 5 centimeter.
Also, will you not confirm diagnosis? Will you not want to know if it's going or not? Won't you do a biopsy?
Oh yes, sir. Sorry. Okay, sir. Investigations and then management.
Yeah.
Okay, sir. I'll be doing a biopsy to confirm it. Then, based on which layer it is involved, I'll be grading it. and based on which grade the melanoma is after staging it to
What type of biopsy? Is there any difference between the biopsy you take for a melanoma and the biopsy you take for a, let's say, like a suspected squamous cell carcinoma? Is there any difference?
Mm, in squamous cell carcinoma, we usually take an edge biopsy, sir.
Okay.
Whereas it's not the case for melanomas.
Okay. What kind of biopsy do you take in melanoma?
Excision biopsy.
No, no. Like excision we can do. Like if it's like very small, we can do a excision biopsy. But there's something called a punch biopsy. When why do we do a punch biopsy?
Uh, because it will take in consider in all the layers of the skin, sir. So we
Yeah,
can clearly identify.
we need the prognosis of melanoma, the management of melanoma, the margin for excision we are going to plan is dependent on the depth of the lesion. So
Depth of.
you need to know the depth of the lesion before you go for surgery. So it's important that we do a punch biopsy. Whereas in squamous cell carcinoma or seminal carcinoma, we take a edge wedge biopsy. Why?
Because there is necrotic tissue that is present in the center of the tumor, sir. So
Okay.
we taken the edge biopsy to compare with normal tissue as well as the tumor.
Yeah, we need to compare like malignant region with the normal region. That's why we do a HL test. Say, what are the gradings you know of like melanoma after biopsy? Let's say like we need to grade the melanoma.
So
What's
we can do Breslow's grading, sir, where
okay?
okay, less than 0.75 millimeter is grade 1, 0.75 to 1.5 is grade 2, 1.5 to 4 millimeters grade 3, and greater than 4 millimeters grade 4.
Okay. Why does the depth of invasion matter?
It depth of invasion changes our the treatment approach as well as the prognosis of the patient.
Yeah. Uh, like the do you what is the margin that you'll give for like each stage of the depth of invasion?
So, if it is extremely small, say less than 1 centimeter, I mean less than 1 millimeter, we give a 2 centimeter margin, sir. And greater than that, we give a 5 centimeter margin.
You need to go back and see it.
All right.
Like let's say like do you do a like this let's say like there's one suspicious lymph node. Like, is what do you do then?
One suspicious.
Lymph node in the region draining that lesion.
Okay, sir.
What do you do?
I would. I would do an FNAC of the lymph nodes, sir. If it is
Okay.
extremely small, I'll do an ultrasound guided FNAC and see if
Okay.
tumor.
Is there a role for sentinel lymph node biopsy in melanoma? Like, do you know what a sentinel lymph node is?
Yes, sir. The first lymph node draining the lesions.
Okay. What are the chances do you know that has a sentinel node?
What other?
Like
Breast.
what? Yeah, breast has a sentinel node, and we do a sentinel node biopsy if it's early. What other chances do you know that has sentinel node? Does carcinoma penis have a sentinel node?
Ethnic cancers, sir.
Like, do you know what the lymph node is called in a CA penis patient?
See, the node varies based on which part of the penis is involved, sir.
So, let's say like you told me the stage is metastatic and advanced. You only can do palliative chemotherapy, right? What are the chemotherapy agents you are going to use?
So there are various regimens that could be employed, sir. There is uh, Folfox regimen can be used. and we can use specific drugs like cyclophosphamide, with and Controvin, along with prednisolone, sir. And also, in recent times, there have been the usage of immunological agents like dabrafenib, ipilimumab. So those kind of agents have shown great responses to
Okay.
melanoma.
Yes, all these targeted therapies have revolutionized the treatment of melanoma. What is the mechanism of action of those? Like, what does those monoclonal antibodies target?
So dabrafenib is a BRAF inhibitor. So BRAF is usually involved in cell proliferation. So there is extreme proliferation due to this BRAF mutation. So this drug dabrafenib targets on that. And ipilimumab is a immune checkpoint inhibitor. So there are various checkpoints in cell cycles. So this directly inhibits those checkpoints due to us.
Well done, Roshan. We get back.
Okay, sir. Thank you, sir. So I can leave. Thank you, sir. Thank you.
Good afternoon, sir.
Hello, Hemant. Is that your name?
Can you hear me,
Yeah.
sir?
Yeah, I can hear you. Can you hear me?
Yes, sir. Yeah.
You can start your presentation here.
Yes, sir. Can you see my?
Yeah, I can.
One minute, sir. Can you see the presentation, sir? So I can't hear you, sir.
Yeah, go on, bro. I can see you.
Okay. So good afternoon, sir. So my name is Hemanta. I'm a final year student from PSG IMSR. So today I'm going to be talking about been titled as hematuria and unassuming diagnosis. So whenever a patient comes with hematuria, one of the first things that we think of is urinary tract infections, urinary stones, or some form of injury, some form of trauma to the genitourinary tract, or even malignancy. But this case is a bit unique. We'll see how it is. So the patient was a 12-year-old male who presented with complaints of fall, following which he had abdominal pain for 3 days, red-colored urine for 3 days, and fever for 1 day. The child was apparently normal 3 days back, after which he sustained a fall from stairs, following which he developed left-side abdominal pain with red-colored urine for 3 days, and the child had developed fever in the past 1 day. There was no other significant present history. With regards to past history, there was no significant history, no significant family history, and the antenatal history was uneventful. Birth history, the child was delivered at term via normal vaginal delivery. The child had cried at birth and weighed 2.7 kilograms. The child was in pain. There was no visible pallor, icterus, cyanosis, clubbing, or lymphadenopathy. And the pulse was 118 per minute, and the SpO2 was 99%. The child was afebrile. On systemic examination, on inspection of the abdomen, it appeared full in the left lumbar and hypochondriac regions, and the umbilicus was in midline. And the left lumbar and hypochondriac region showed reduced movement with respiration, and there were no scars or sinuses or dilated veins over the abdomen. On palpation, tenderness was elicited over the left lumbar and hypochondriac regions with no warmth, and a vague mass was felt in the same regions. Percussion and auscultation were revealed nothing significant. So we had made a provisional diagnosis of some form of solid organ injury, possibly the kidney or spleen, with having it to be more likely to be kidney due to a history of hematuria. The child was subjected to subsequent investigations whose results have been mentioned below. So the child's general investigations were normal except for hemoglobin of 11.8, and the urine analysis showed a reddish cloudy urine with a chemical analysis of the urine showing presence of leukocytes in RBCs and nitrates. And urine microscopy showed increased RBC count and mild increase in WBC count. On imaging via ultrasound, you can see that there was a hematoma surrounding the left kidney with grossly thinned out parenchyma and dilated pelvic calyceal system. On CECT of the abdomen, the left kidney was grossly enlarged with severe hydronephrosis, with the left renal parenchyma being thinned out, and the renal pelvis was also dilated with thin wall enhancement. So this is suggestive of chronic obstruction in the pelvic junction. And the left ureter was undilated, and there was also presence of fluid in the perinephric space with a renal and paracolic gutter. And the renal artery was small in caliber. So diagnosis was made as the pelvic junction obstruction which had undergone a rupture. So with regards to management, the patient was initially stabilized with IV fluids, antibiotics and analgesics, and under strict aseptic precautions with anesthesia. An ultrasound guided pigtail catheter was placed in the left kidney, and the patient was advised to return after 4 to 6 weeks. On the second visit, the patient was subjected to an EC scan, which showed a differential function of 5% in left kidney and 95% right kidney. So this showed reduced renal function in left kidney. So the management undertaken was an open left nephrectomy, which was done under general anesthesia with epidural analgesia. And with good access to hilum, the peritoneum was pushed medially, the gyrotous fascia was opened vertically, and the surrounding fluid was drained and emptied, and the vessels were ligated, and the hilum was dissected. And with proper clearance of the adrenal gland and the pancreas, pelvis was dissected medially, and the nephrectomy was done. So here in this slide, we can see that the post-surgery, the child had a healthy scar, and on the right side, we can see the specimen of the left kidney. It showed a thinned out parenchyma with a grossly dilated pelvis. It was subjected to biopsy, which showed atrophic tubules with extensive glomerulosclerosis. So what I would like to express from my presentation is that as clinicians, we should always have an open mind to suspect uncommon conditions, and in case of any trauma, patient stabilization takes priority over everything else. With regards to the case, pelvic junction, the normal mode of treatment is usually pyeloplasty. But if the differential renal function is less than 10%, nephrectomy is the option that is usually taken up. And with patients who have undergone nephrectomy, they have to be followed up long term to look for any superseding hypertension. Thank you.
Good presentation, Hemant. This is a case of pelvic junction obstruction that led to hematuria after trauma, right?
Yes, sir.
So hematuria is a very broad diagnosis and it's a broad symptomatology. So, what are the two main types of hematuria?
So we can have microscopic and macroscopic hematuria, sir.
Okay. When do you call it microscopic? When do you call it macroscopic?
When there is no gross visible discoloration of the urine, it is microscopic hematuria. When the RBC is only found on microscopic examination,
Okay.
and it is grossly visible reddish urine, it is macroscopic hematuria.
Okay. Like what will you find? Will you find actual RBCs or will you find RBC cast?
There can be RBCs, or there can be ruptured RBCs, or RBC cast can also be present.
Okay, if you find an RBC cast, what does that signify?
A urinary tract infection.
Okay. What, like, let's say there's a case of glomerulonephritis.
Okay, sir.
In the case of glomerulonephritis, like the hematuria might be like microscopic or macroscopic. And if it's like microscopic, will you find an RBC or a RBC cast?
RBC cast, sir.
Okay. Yeah, so in a glomerular pathology, we usually find a cast. Okay. Okay. In terms of like the correlation between like maturation and hematuria. Like, can you tell me like different locations of pathology and like how the hematuria will be like in these cases? Let's say there's a renal cause of hematuria, how will the hematuria be? Let's say there's a prostatic cause of hematuria, how will the hematuria be? Can you explain?
Um, I'm not very sure, sir.
Okay, let's say someone is having hematuria throughout the entire stream. Like, do you know where the lesion is?
Um, in the renal, sir, probably in the kidney.
Okay. Let's say like there's a clear stream of urine followed by hematuria towards the end of it.
Probably a bladder or urethral pathology.
Okay, let's say like there's hematuria of fresh blood during the start of maturation. அதுக்கப்புறம் like after that it's just clear urine. Like all these symptomatology is very important in hematuria because it's very important in the diagnosis of the cause of hematuria. Okay. See, okay. With regards to the age of the patient with hematuria, let's say, like this is a child with hematuria after trauma. Let's say you find a young athletic guy who's a sports person, like who has hematuria. What will you do? Will you be worried or do you think it's normal?
So if the sport person, there could be a risk of blunt trauma to the abdomen depending on the sport. So if there's any blunt trauma to the kidney, can lead to laceration of the kidney causing hematuria.
Okay. So, okay, let's say like there's a 60-year-old guy like who has hematuria versus a young guy with hematuria. Do you think both the cases are the same?
No, sir. If it is as the age exceeds, we should suspect more of renal cell carcinoma as a differential diagnosis for hematuria.
Okay. Going into renal cell carcinoma, like what other symptoms will the patient have if it's a renal cell carcinoma?
So usually renal cell carcinoma has a usual triad of any flank mass, pain, and hematuria. And if there is extensive metastasis, they can also present with bone pain, pathological fractures, or hepatomegaly if there is liver metastasis.
Okay. Do you know like one peculiar feature of the renal cell carcinoma? Like,
Painless hematuria. Painless,
what's the very peculiar feature of renal cell carcinoma?
painless hematuria, sir.
Okay, like with regards to like the blood vessel, it's IVC or renal vein. Like, do you think there's
But it spreads by the IVC, sir. Carcinoma spreads via the
like it's like renal cell carcinoma has a tumor thrombus. It's very peculiar to that. Like, let's say like there's a tumor thrombus in the left renal vein. What else will you look for?
There will also be presence of scrotal varices due to obstruction of the drainage of the glomerular vein.
Yeah, you'll have to see varicocele of the left side. Like, this is why in an old patient that has hematuria and you're able to see a varicocele, like it's most likely due to malignancy. So you should always examine the scrotum in an older patient. Yeah. What are the types of renal cell carcinoma?
So renal cell carcinoma, we have clear cell type,
Okay.
then we have medullary type, chromophore type, then keratin duct, and papillary carcinoma.
Okay. Let's say in the case of renal cell carcinoma, do you think the patient's BP will be normal or will it be like altered?
Patients tend to be hypertensive, sir. They will
Yeah.
have increased blood pressure.
These are the things you should look for. Huh? Okay. Like what? Let's say there's a newborn that. Like what are the other conditions in a child or newborn that you know that can cause hematuria?
Wilms tumor can cause hematuria in a newborn.
Okay. What else?
Um, Wilms tumor. There can be any neonatal urinary tract infections
Okay.
or polycystic kidney disease.
Okay.
That's all I know.
Um, um, let's say hematuria after trauma, and like in this case, you had trauma followed by hematuria, right? What are the what other instances can you think of that has like trauma related hematuria?
Um, the iatrogenic trauma.
Yeah, good. That's very common, right? Like, what is the most common cause of yeah?
Catheterization.
So, how can you avoid like catheter related injury to the urethra?
So usually, while one of the most important things while catheterization is to retract the prepuce before catheterization
Okay.
and to properly place it back after catheterization. And
Okay.
while
Why do you
placing
have to like retract it properly and place it back properly? What is the complication that will happen?
paraphimosis can occur.
Okay, I'm asking you like how. Okay, that is an important point. But how do you avoid urethral injury? That is to avoid paraphimosis. How do you avoid urethral injury while catheterizing patient?
So while catheterization, when we inflating the balloon of the catheter, we have to make sure that the balloon is not inside the urethra and is properly inside the bladder
How do you
before
confirm?
inflating. So we can look at it using ultrasound guidance.
Okay, like give me a simple answer. Like, give me a simple like finding that tells me that the catheter is in the bladder.
Um, the flow of urine in
Yeah.
the bladder.
Once the catheter passes the bladder outlet and it is entering the bladder, you will see a stream of urine. Then you can be sure that the bladder is in the catheter is in the bladder. Okay. Let's say like you inflate the catheter inside the urethra and there's injury, urethral injury. What will you do? Will you remove it or will you let it stay there? What will you do?
Um, so if we remove, there's risk of extravasation of urine into the perineal space,
Okay.
and
Okay. Usually, management is to like even if you cause urethral injury, what most urologists will do is they'll like if you had removed the catheter by then, they'll try recatheterizing with a smaller uh, size catheter. It has to be done very carefully. Like if you don't do it properly, it can lead to serious injuries. Once you recatheterize the patient, the urethra will recanalize over the catheter. Okay, then yeah, there are like risks for stricture after recanalization. That is why you should try your best to avoid injuries at all time. Like a patient should not have like a difficulty in passing urine for the rest of his life just because we did a mistake. That's something that we should be very careful in avoiding. Let's say like what are the causes after catheterization? You're not seeing urine. What will like you're very confident that the catheter is in the bladder, but you're not seeing urine. Like what can be the reasons?
um, so, possibly the patient could have emptied the bladder prior to the
Yeah,
procedure.
that is a possibility. But you're able to feel a full bladder per abdomen.
So probably any stone or stricture obstructing the.
Yeah. First, you should think about simpler things, right? Like you use lignocaine jelly, right, before inserting the catheter. It could be blocking the opening. So you need to flush saline through the opening and see if like it's because of that. That is the first thing you should do. Let's say there's a retained catheter. You cannot remove the catheter after catheterizing the patient. What will you do? You're
Um,
not able to deflate the balloon.
so we can do ultrasound guidance and deflate the balloon suprapubically. And,
What will you do under ultrasound guidance?
um, so we go into the bladder and uh, we will pierce the balloon so that the
Yeah.
fluid extravasates out, and we'll.
What other options do you have?
I don't know.
Okay. You can actually pass volatile gases through the opening so that it will burst on its own, but that is not something we do often. Like what we do is ultrasound guided percutaneous rupture of the balloon. That is what we do. Okay. Okay, Hemant. Nice presentation.
Thank you, sir. Thank you.
Hello, sir.
Hi Gitanjali, like you can carry on with the presentation.
Sir, is it visible?
Yeah.
Hello.
Hello Gitanjali, yeah, I can see the slide. You can carry on with the presentation.
The IPV in Gitanjali GMC Core Code, and today I'm going to present a case of retroperitoneal mass. So, our patient is a 59-year-old male hailing from North Kerala. He's a painter by profession, leading an active lifestyle. He's coming from a low socioeconomic status and is on insurance. Coming to the history, the patient presents for unilateral lower limb edema on the left leg associated with pain. The pain is continuous, progressive, not associated with any erythema, any other symptoms like nausea, vomiting, fever, night sweats, etc. No history of associated chest pain, any sudden onset shortness of breath, palpitations, hemoptysis. No history of any recent trauma or immobilization. No history of any flank pain, abdominal pain or back pain. No history of any weight loss or loss of appetite or numbness on legs. No history of any urinary or bowel symptoms. And there is no ulceration on the back of the leg or blackish discoloration. There is also no history of hematuria. The patient was evaluated at a local hospital for unilateral lower limb edema and treated with oral medication, later evaluated with a Doppler, which showed that evidence for DVT and anticoagulation was started. The patient had persistent symptoms for which he himself wanted opinion from a higher center and hence came here. The past history involves him having a labyrinthectomy done in the right ear 20 years ago. There is no other history of any malignancies in the past and no relevant medical history. Family history also, there is no history of similar illness in the family. And personal history, he's on a mixed diet, appetite is normal, bowel and bladder habits are also normal, and there is no history of addictions in the past. There is also no relevant drug history. Coming to the general examination, he is conscious, cooperative and oriented, moderately built and nourished. Unilateral pitting pedal edema on the left leg was found, and pallor, cyanosis, clubbing, lymphadenopathy, varicosity of veins and thyroid swelling was not present. All pulsations was palpable, including distal pulsations, but the left femoral pulse, the popliteal pulse and the left dorsalis pedis pulse were lower volume compared to the right. Coming to the abdominal examination done after obtaining consent with adequate illumination in supine position. Inspection, the abdomen was slightly distended, umbilicus was central, inverted. All quadrants were moved equally with respiration, no stars, sinuses or dilated veins. Palpation, the mass of size 5 into 5 centimeter over the right iliac fossa. Superior border 5 centimeter lateral from the left anterior superior iliac spine, medial margin 8 centimeter above and 2 centimeter lateral to pubic symphysis. The lower border was not palpable. It was hard in consistency, had a smooth surface, it was not mobile and not moving with respiration. The lower margins could not be felt and it was non-pulsatile. The liver span was we percussed and a resonant node was obtained on percussion, and the liver span was 30 centimeter. No fluid thrill or shifting dullness was found. Parietal examination was normal and the genital examination was also normal. Coming to investigations, the total count was normal. The HB was slightly on the lower side with the platelet count being normal and the PTINR also being normal. The RBS was normal. RFT was slightly elevated and the serum creatinine and urea was elevated. Electrolytes, total bilirubin, conjugated bilirubin, total protein and albumin was also normal.
AST LT was also normal, and the blood group was O positive. Screening was negative. Chest X-ray was normal. ECGs was normal. The USC venous Doppler showed a left lower limb DVT involving the superficial femoral vein and the common femoral vein. And the USG indicated a hypoechoic lesion involving the left iliac fossa with compression of the distal ureter with upstream hydroureter nephrosis. There was also enlarged lymph nodes. And true cut biopsy indicated a spindle cell neoplasm of smooth muscle origin, high mitotic count, and atypical cells. Immunohistochemistry showed diffuse positivity for SMA and focal positivity for DESME. MRI was done, and it showed a lesion encasing the vessels involving the urethra, as you can see here. And the provisional diagnosis we had was a retroperitoneal sarcoma. And the patient was treated with rivaroxaban for DVT since 3 months, and preoperatively cardiac evaluation was done, echo was done, and it was changed to low molecular weight heparin. Explorative rapprotomy was done, and a lower midline vertical incision extending to the left inguinal was and the findings was mass of 12 into 10 into 10 centimeter arising from the retroperitoneum. There was encasement of the left ureter with left hydroureter in the tumor mass, and encasement of the left iliac vein. There was thrombosis of the left iliac vein, and the encasement of the left iliac artery was also present, and infiltration of the left psoas muscle and medial border was also there. So we did an MMAS R0 excision of the mass with psoas muscle, lower ureter, artery from common iliac artery to the femoral. There's an arterial TTFE graft and a ureter. We have is all cases of DVTs, if not associated with any antecedent causes, through thorough evaluation should be done for intra-abdominal mass, especially retroperitoneal and renal masses. Here, the retroperitoneal mass was quite big, but we chose for a tumor resection, R0 resection. It should be done if possible, if there is a functional outcome, as it's the best course of action for a retroperitoneal mass. And a multidisciplinary approach should be taken, and adjuvant should be mainly radiotherapy. Thank you, sir.
Gitanjali, that was a good presentation. So your diagnosis was retroperitoneal sarcoma. How did you classify it as retroperitoneal?
Sir, could you repeat the question?
How do you say it's a retroperitoneal lesion? Like, from the history and examination, what are the findings you had? That
Not bad. So we firstly it did not fall forward. Fall forward in the elbow position. So that the retroperitoneal along with the resonance.
okay. Gitanjali, your audio is kind of not clear. Like, can you fix that? Like, is there a way you can fix it? Yeah, your audio is like not clear. Yeah, better. So you told you do a knee elbow. Do we advise doing knee elbow position for all patients nowadays? Like, is it a compulsory investigation, compulsory examination?
Yes, sir. Am
Uh,
I audible?
yeah, like you said, like you confirm that it's a retroperitoneal edema based on the knee elbow finding, finding, right? Like, is there an alternative to that? Like a more convenient, more patient-friendly question to see if it's retroperitoneal or interperitoneal?
Point is,
Hello.
ma'am, point.
I think there's some issue with the connectivity. Are you able to hear?
No, sir.
No? Are the other people able to hear me? Okay. Are you able to hear me now? Like, can you fix the connectivity issue?
Point, sir.
Can you fix
Can
it?
I join from another? Hello?
Yeah. Like, are you able to hear me now?
No, sir. I am able. Can I join from another?
Uh, am I the only person having the issue, or like all of you are having?
Hello, sir. Can you hear me now?
Yeah, it's better now. Yeah,
Sir.
yeah,
Yes.
a lot better now. Yeah. So you were telling you would do the question for this patient, right? Like, is there an alternative to that?
The retro to check the mass system.
What?
The tag. Yes. Can I join from another device?
Yeah, no problem. Yeah, do that.
Sir,
Yeah. Hello.
hello, sir.
Yes. So you were telling me that you let's start the discussion again.
Okay.
What are the different planes of swelling in that zone?
Sir, it can be retroperitoneal, peritoneal, or it can be parietal, front of the parietal peritoneum, sir. It can be
Okay. So it's divided into parietal and and
intraperitoneal, retroperitoneal.
it can be intra-abdominal or like retroperitoneal, right?
Yes.
Yeah, like let's say what is the finding that you'll say uh, like to confirm a lesion is parietal? Like what
Leg racing test, sir. Leg racing test.
okay, like what will you find if it's a parietal lesion?
Sir, when we do leg racing test or when we cross the parietal swelling will while the intra-abdominal swelling will go away.
Okay, give me like a few examples of a parietal lesion.
Sir, lipoma can be a parietal lesion, it can be liposarcoma,
Okay.
it can be of muscular origin, muscular tumor.
Like, are you familiar with something called a uh, hematoma of the rectus? Like,
Yes, sir.
okay. How will that present?
Sir, the hematoma of the rectus, it will be a more prominent leg racing test. If it's
Okay. Okay. If it's intra-abdominal, what will happen? What will happen in head raising or leg raising?
if it's intra-abdominal, sir, while regulating it, the muscles will contract and the lesion will be less prominent.
Okay. If it's retroperitoneal, what will happen?
Retroperitoneal, sir, there won't be a change to the, any leg racing, sir. It will become less prominent.
Okay. How will you differentiate between intra-abdominal and retroperitoneal?
Mainly, if the lesion is falling forward, it's an intra-abdominal lesion.
Okay.
Then if there is a dull note over percussion, on percussion, it's a dull, it's an intra-abdominal lesion. But for retroperitoneal lesions, the note is mostly continuous.
Okay. Let's say like there's a swelling from the liver. What are the findings you will have if it's a liver swelling?
Sir, movement in case of a liver swelling, we can differentiate it from a diaphragmatic swelling. It will have rigorous movement with respiration. But in case of a liver swelling, it will move with respiration. But retroperitoneal tumors don't move with respiration at all.
You should say that. You should say that, on the point differentiating between intra-abdominal and retroperitoneal. Like this moves with respiration. Okay, what are the intra-abdominal organs that move with respiration? What are the organs that do not move with respiration?
Intra-abdominal organs that move with respiration mainly are stomach moves.
Okay.
The small intestine moves. The ascending descending colons, they are retroperitoneal, so they don't move. Pancreas, the duodenum, the kidneys, and the adrenals, they don't move. But the rest of the organs, including the spleen.
Okay. There's a controversy, right? Like some would say that kidneys do move with respiration, like indirectly because of connections with the diaphragm. There's like lenorenal and all those ligaments, right? Like the phrenicorenal, those ligaments kind of the kidney does move with respirations. Like moving on to sarcoma discussion, like what do you call a sarcoma? Different sarcoma.
Sarcomas are cancers of the soft tissue origin. They are of the soft tissue origin, so mostly it's of mesothelium origin.
Okay.
And they can be of smooth muscle origin. They can be of of adipose tissue, from adipose tissue.
Okay. How does a sarcoma start? How, like, let's say like a lipoma, like can a lipoma become a liposarcoma?
Lipoma can become a lipoma. There can be any insult, there can be like a trauma or anything that's causing an insult to the tumor can make it a liposarcoma. There can also be genetic predisposition.
Like, have you heard the term like de novo genesis? De novo genesis of sarcoma. Like earlier, we used to think that sarcoma was from a pre-malignant lesion. Like lipoma can become a liposarcoma. Like even in some books, they say that like lipomas in certain areas, like the thighs and retroperitoneum, can become liposarcoma. But the widely accepted theory is that sarcoma doesn't start from a different lesion. It starts de novo. It doesn't start from an already existing lesion. It just starts de novo. That's the existing pair. What are the common places you can see a sarcoma?
The muscle can be of smooth
In
muscle.
parts of the body, like which part of the body it's more prominent, most common region for area for a sarcoma?
So the pelvis.
So it's the lower limbs. It's like especially the thigh. The second most common is retroperitoneal. Okay, like which has like a poorer prognosis, the lower limb or the retroperitoneal, which has like poor prognosis.
Sir, I think the retroperitoneum, because more times if it's not if the histogram, it will be hard to resect, and then mostly the patients come in very late.
Yeah, good. Retroperitoneal sarcomas, they present very late, so they usually have like poor prognosis than sarcomas of the extremities. Okay, let's say like you diagnose the sarcoma, like you have a lesion. Like let's say you have a soft tissue lesion in the thigh. What are the features that will make you suspect that it's not just a lipoma? It might be something more than a lipoma. It might be a malignancy. What are the points in?
Especially if there is pain, it can indicate neurological involvement, nerve infiltration. And if the patient presents, like in this case, if he presents with any systemic symptoms, and especially if there is for example, weight loss, loss of appetite, and in other symptoms of cataplexia,
Those are symptoms that come after metastasis, right? Like I'm
yes,
asking, if there's a soft tissue lesion in the thigh, right? Like let's say like there's a 8x8 lesion in the thigh. So like any let's say like even if you find a lipoma that's more than 5 centimeter, you should always think about like the possibility of sarcoma. You should always do a
um, five,
and especially if it's in the thigh or the highly the areas that are prominent for sarcomas, that should give you the suspicion of it being more than just a soft tissue lesion, benign lesion. Okay, how will you confirm the diagnosis?
sir, preoperatively confirmed the diagnosis, sir.
Yeah,
Sir, we did a CT and we had found the tumor. We did a true cut biopsy, and the true cut biopsy mainly confirms the diagnosis, especially with the high mitotic rate and atypical cells.
okay,
Then, sir, an MRI can be done to assess the invasion.
okay.
Then, um,
Okay, so what are the features of a sarcoma? Like, let's say there's a sarcoma. What are the pathological features of a sarcoma? Like, will it be very vascular? Will it be vascular?
sir, yes, sir, it will be as well.
Like, how will the consistency
Sir,
be? The consistency of a sarcoma.
sarcoma, sir, it will be hard, sir. Mainly,
Okay. Like, just because of the increased vascularity, like, what other features will you have? Like, will you feel warmth? Will it be warm?
yes, sir. It will be warm and it will be causing symptoms like malaise and loss of weight.
Okay. Let's say you do a true cut biopsy and a lesion that's 10 centimeter big, and the true cut biopsy comes out as lipoma. What will you do?
Sir, mostly we won't resect it if it's not that big.
No, like I'm asking you, like there's a 10 centimeter big lesion in the thigh. You do a true cut. The biopsy comes back as lipoma. What will you do next?
Sir, we would advise the patient to resect it as it has a malignant potential, but it can be elective surgery.
Okay. Let's say like while doing like before diagnosing the sarcoma, like is there any role for incisional biopsy in the sarcoma?
Sir, we don't usually do incisional biopsy in especially if it's intra-abdominal. There is risk of peritoneal
Intra-abdominal, let's say like a peripheral lesion. Right?
peripheral lesion.
Abdominal, like it's complicated, right? You get a biopsy.
Sir, true cut biopsy, I'm not aware, sir.
Huh?
I'm not aware.
Okay. Okay, let's say like you do the biopsy and you get the report as like sarcoma. What is the most important prognostic factor in the sarcoma? Pathological prognostic.
Especially, sir, resectability and the metastasis, sir. How
Okay.
much we can resect out, whether it's an R0 resection, and how much it is, like the stage it is in.
Okay. Are you familiar with something called mitotic activity?
Yes, sir.
Is it important in the sarcoma?
Yes, sir. If there is high mitotic activity, there is chance of it
Yeah.
like seeding and also it growing more and having more vascular.
Important prognostic factor in a sarcoma case. In fact, they use the mitotic activity as a feature for staging the disease. Yeah, so it's very important. Okay. Let's say sarcoma that is resectable in an extremity. What is the margin you'll get?
Sir,
How much margin will you give for excision of the sarcoma?
sir, 10 centimeters.
How much?
10 centimeters.
5.
10 centimeters.
10 centimeter. Oh, 10 centimeter is very good. Like 10 centimeters is like a lot of tissue. Let's say like if you give 10 centimeter in the leg, you'll have to take out the entire leg. Okay, so Okay, there are certain rules and doing a resection of sarcoma. Like let's say if it's like in the retroperitoneum, right? Retroperitoneum, let's say in the periphery, extremities, that's easy to operate on. If it's a fascia, if it's a bone, that can be a margin. All the other regions, like 2 centimeter margin is sufficient. You exercise that. And is there any role for chemotherapy or radiotherapy?
Sir, in this case, or
In general, any sarcomas?
sir, yes, sir. Chemotherapy is advised. Either neoadjuvant chemotherapy or adjuvant chemotherapy can be advised.
Okay.
But in retroperitoneal sarcoma, maybe we can use the regime advised, uh, the MAID regime, sir. But like
Which has which is more important, radiotherapy or chemotherapy?
radiotherapy, sir.
Um, are you familiar with the term called compartmental excision?
Compartmental excision, sir, I'm not that familiar.
Okay. That is something we do in like extremities, sarcomas of the extremities. What we do is we excise an entire compartment of the thigh. Let's say sarcomas in the anterior compartment or medial compartment, we excise the entire compartment till that fascia, and that is something that is very debilitating. We do not do that. Generally, if there's any sarcoma of the extremities, the approach we take is limb preserving, function preserving surgeries. Will you go for an amputation in the case of sarcoma?
Yes, sir. Yes, sir.
When will you do an amputation?
Sir, if there is extensive involvement, good big, if it's a big lesion and there is like involvement of the surrounding tissue, we will choose for amputation, sir.
Will you do it early or will you do it later?
Early, sir, because if there is like peripheral mets doing an amputation.
No. Amputation is the last resort in the case of sarcoma. Like what we'll try doing is a wide local excision. Only if like wide local excision is not possible and compartmental excision is not possible, amputation is the last resort. Amputation is something that we do only if there's no other option. Okay. Okay. You did well, Gita. Hello. Pavitra?
Sir, we are done with the surgery case presentation.
What?
Surgery case presentation, sir.
Okay, yeah.
We would like to thank you, sir, for your time and also thank you, sir, for accepting our offer. Thank you, sir. Janani, you can start presenting your case.
Is my screen visible? Hello? Is my screen visible, ma'am?
Yes, Janani, you can proceed. Your screen is visible.
Good afternoon, ma'am. I am Janani R from Sri Muthukuman Medical College. I am a pre-final year. Before starting my presentation, I like to thank my HOD ma'am and assistant professor ma'am for giving me this case. So this is a brief of the patient came to our hospital. So a 34-year-old female, a homemaker from Kundatur, she came to our emergency department on 25th July. She had a complaint of lower abdominal colicky pain for a day which radiated to her back. So our casualty medical officer, after taking the history and performing basic examinations, asked her to take an USG whole abdomen scan. So in that we found that she had bilateral permanent ovaries, so she was referred to the gynecology department. So in the gynecology department, a thorough history was taken, and as a part of examination, a transvaginal scan was done. So in this, it revealed and left adrenergix mass. To get an expert opinion, she was then referred to the radiological department. Then that same patient on 21st August, she again came to the gynecology OPD with similar complaints like the lower abdominal pain for one day, which was the colicky type of pain, and it also radiated to the back. And she also had two episodes of nausea and vomiting. So she had the MRI report which showed the presence of Bernard tumor, ma'am. Apart from it, she had no complaints of any irregular menstruation, no history of constipation, increased frequency of urination or mass per abdomen. Uh, Moving on to her menstrual history, she attained menarche at the age of 13 years. Her cycle was regular with 30 days, and her menstruation each lasts for about 4 days, and her flow was regular. There was no history of passing any cause or lower abdominal pain. Her marital history, she was married for the past 10 years, which was a non-consanguineous marriage. And obstetric history, her obstetric score was P1, L1 and A2. So she has one female child, she was delivered via the LSCS 8 years ago. Apart from it, she underwent two MTPs. One was 8 years ago, and another one was 6 months ago. Past history, she had a history of bronchial asthma till her age of 18, and also a laparoscopic appendectomy was done when she was 15-year-old. Apart from it, she was not a known case of diabetes mellitus, hypertension, tuberculosis, any thyroid disorders or Schizo disorders. Her family history, there was no significant complaints in the family, like any ovarian tumors or breast cancers among her mother or any first degree relatives. So examination part, the patient was conscious and cooperative. She is moderately built and nourished, well oriented to time, place and person. Anthropometry measures, she weighed around 62 kgs, her height is about 150 centimeters. Her BMI is 27.6. Her vitals, her temperature, it was afebrile around 98.7 degrees Fahrenheit. Her BP, blood pressure is about 110/70 millimeters mercury. Her pulse is 84 beats per minute. Respiratory rate is 14 breaths per minute. No signs of pallor, icterus, clubbing, cyanosis, pedal edema, and lymphadenopathy was noted. In systemic examination, CNS, there was no focal neurological deficit noted. CVS, normal S1, S2 sounds heard, no murmurs. In ours, normal vesicular birth sound was heard. There was no added sounds. In per abdomen, it was soft, no organomegaly, and all the quadrants of abdomen moved equally during the respiration. A mild tenderness was noted in the left iliac region. In genital examination, external genitalia, which appeared normal. On perspectrum examination, the cervix appeared healthy. On pervaginal examination, the cervix appeared pulled up. The uterus was anteverted and bulky, and left pharyngeal fullness was noted. Per rectal examination, there was no nose and perimetrium is free. The cervix is pulled out due to the past LSES. As I mentioned in the history, and USG whole abdomen was done when she first presented to the hospital at 21st July. So its report is her bladder was diffusely thickened, her uterus was normal, and it showed post LSES status. It measured about 10.3 cross 3.4 centimeters. Her ovary, both the ovaries was prominent. Right and in right ovary, there was mild polycystic changes were noted, and it measured about 4 cross 2 cross 2.6 centimeter. And left ovary, it measured around 6.5 cross 5.3 cross 4.5 centimeters. So on the subsequent day, the MRI was taken, and in the left ovary, on T1, it was heterogeneously enhanced. So here we can see in the T1, it was heterogeneously enhanced, and apart from it, and T2, it was hypodense lesion, and it showed a tiny hyper intense follicle. So this is the T2, which is hypodense, and in center we could see some fleck of foci of hyperdense lesion. And apart from it, a minimal free fluid was seen in the pouch of Douglas, that too towards the left adnexa surrounding the left ovary. The left adnexa also showed prominent veins. The right ovary showed multiple follicular cystic lesions. So this is the right ovary. Here we can see multiple follicular cysts. Subsequently, CT screening was done, which also showed the left ovary as a hyperdense with multiple tiny specks of calcifications. So the radiological impression is that a fibrous containing tumor, which is arising from the left ovary, with a possibility of Burner tumor. Subsequently, the other investigations like the blood investigation, the urine routine, renal function test, the liver function test, and the tumor markers were done. All are be found to be within the normal range. The tumor markers within the normal range shows benign nature of the tumor. Serology was done on all the markers like the hepatitis, HBsAg, the HIV and VLDR all are found to be non-reactive. So the provincial diagnosis were made based on the history and the examination as T1L1A2, a previous LACS with left ovarian Burner tumor. For the management part, the left salpingo-oophorectomy was done. So the surgical procedure. Under spinal anesthesia, the patient was put in the lithotomy position, and under aseptic precautions, the sites to be operated are painted and draped. Using a SIM speculum, the posterior vaginal wall was retracted and the anterior lips of cervix were held with a valsalum. So the length of the whole uterus is measured with the help of uterine ultrasound, and the cervix hose is serially dilated with the help of Heger dilator, and the endometrial sampling was collected and it was sent for histopathological examination. There was no undue bleeding when noted during this procedure. Next, the patient was put in a supine position and a suprapubic incision was made, and the abdomen was open in the layers. Adhesions was found between the rectus sheath and the anterior abdominal wall, which may be due to the previous LSES surgery, and the adhesions was released with the help of a sharp dissection, and then the peritoneal fluid is aspirated out and it was sent for cytological examination. Then, by clamping, cutting and ligating the left ovarian ligament and fallopian tube medially, on the left infundibulum ligament laterally, the left salpingo-oophorectomy was done for the patient. Then the hemostasis was achieved, and after checking all the instruments and the devices used in the surgery, the abdomen was closed in the layers, and a clear urine was drained via the catheter, which denotes that the bladder is not injured during the surgery. During the operation, we found that the left ovary was replaced by a hard mass which measured around 6 cross 5 cross 3. Apart from it, the left fallopian tube, the right fallopian tube, and the ovaries were found to be normal. The uterus were normal. These are the pictures from the during the surgery. So this is the one marked with a white circle is the uterus. The green circle is our right ovary, and the blue circle is the left ovary. We could say the left ovary is increased in size even more than that of uterus. This is the picture of resected left ovary. On cut section, it looked yellowish white from fibrous mass. Post-operatively, histopathological examination was done, and it showed following features. So, under microscopy, we noted compressed ovarian parenchyma with circumscribed neoplasms nest, which was the Wasat's nest, with areas of calcifications. There was also dense fibrous stroma present in between. So these are the dense fibrous stroma. So in the cell mass, we could see clear cells which are made up of transitional epithelial cells resembling that of a bladder epithelium, and the nuclei of each of it is oval, and they showed a longitudinal groove which is also known as the coffee bean nuclei. Apart from it, the left fallopian tube was unremarkable. The right ovary was compressed and it had multiple follicular cysts. So, the histopathological impression is that the left ovary is confirmed to be of a benign Berner tumor, and endometrium is in the proliferative phase. The post-operatively blood investigations were also found within the normal range, indicating that there was no infections or any inflammation. And in the post-operative period, it was uneventful. The patient recovered well with stable vitals. She was given IV fluids and IV cefotaxime, metronidazole, cefixime was given to prevent any infection. Emised to prevent post-operative nausea and vomiting. Tramadol, diclofenac for pain relief, and Diflac was given to prevent any constipation and strain to the abdomen, and Leogen is iron supplement. The patient was discharged on 28th August. Thank you. Thank you, ma'am.
So, Janani, that was a detailed presentation.
Thank you.
So, since you have already exceeded your time, let's move on to the questions. So, what is a Brenner's tumor actually?
It's a type of epithelial tumor which comes under clear cell tumor, ma'am.
It is an epithelial tumor. Clear cell tumor is a part of an epithelial tumor. Brenner's tumor is another epithelial tumor. Okay, let's not get confused here. So, what is the common age group that you expect Brenner's tumor to present in?
Reproductive age around 20 to 40 years, ma'am.
Actually, all the epithelial tumors, that is the serous, mucinous, Brenner's, endometrioid type, clear cell type, all will have a presentation mostly in the postmenopausal age group. That is likely to be after 45 to 50 years. Your case is rare because it is presenting at 34 years. Okay. So you have done few tumor markers, right? Can you tell me if there is any tumor marker that is specific for Brenner's tumor?
In case of epithelial tumors, CA125 will be mostly elevated. But as Berner is a benign tumor, here the tumor marker was found within the normal range, ma'am.
Okay, so you're suspecting Brenner tumor as per the imaging. But since the age is only 34, you want to rule out other germ cell tumors also, which is likely to be presenting at this age group. So you have done the markers for the germ cell tumor as well as the epithelial tumor. So what are the markers that you did for germ cell tumor?
For germ cell tumor, beta HCG can be done. LDH can be done, ma'am.
Okay. And alpha fetoprotein 2, that is also for ruling out germ cell tumor. Okay. So
Okay, ma'am.
and okay, when you were discussing the histopathology part, you were
Yes, ma'am.
explaining about warthed cell rest, right? So
Yes, ma'am.
what is the pathognomic feature or pathognomic sign in the nucleus that you see in Brenner's tumor,
The nuclei will show a longitudinal groove, ma'am, which is
which
also
is
named
called?
as a coffee bean appearance.
Okay, so coffee bean nucleus is a specific sign for Brenner's tumor, right? As you said, it's just a longitudinal groove in between. Okay,
Yes,
so what
ma'am.
will be the usual presenting symptom or is the presenting complaint in case of a Brenner's tumor?
As it's a benign tumor, mostly there won't be much complaints. They will be mainly found uh, like accidentally, like non-intentionally in imaging.
Okay, so
But
it's mostly asymptomatic. It is an incidental finding in imaging. Okay,
yes, ma'am.
but what can it present with?
If the mass is very large, it can cause any pressure symptoms, like it can compress over the bladder, and there can be any alteration in mixturation, like increased frequency or any feeling of mass in the abdomen, or if it compress posteriorly, there can be constipation, ma'am, or if it compress
Okay,
over the
so most
rectum.
of the times it is asymptomatic, it is only an incidental finding, or sometimes it can present as an abdominal mass, or it can present with abdominal pain. Rarely it can present with pressure symptoms, like you mentioned. And is it a hormone secreting tumor?
Mostly it is not hormone secreting, but sometimes if it undergo malignant change, then it will be called as the transitional cell carcinoma of ovary. Then there can be hormone production, ma'am.
What will it produce in case of a carcinoma?
Estrogen.
So very rarely benign Brenner tumor also can produce estrogen. In which case,
Okay, ma'am.
what will it present with?
If it's in the reproductive age, there can be menstrual irregularities. If it's in postmenopausal stage, then there can be postmenopausal bleeding, ma'am.
Okay, so it can present with features of endometrial hyperplasia, which might be heavy bleeding in the reproductive age group, or as you said, it can be a postmenopausal bleeding. Okay, one thing I wanted to confirm was what was the procedure done actually?
Left salpingopectomy, ma'am.
But in your histopathology report, you mentioned about the right ovary also. Was it also removed?
It was not actually removed, ma'am.
Then why did your histopathology report had comment on right ovary? Okay, that was a mistake, right?
Yes, ma'am.
Sure, okay. I'll have a final question for you. What is RMI scoring or risk of malignancy index scoring? Okay. So, since you keep insisting that it is a benign Brenner tumor and benign Brenner tumor, what is a borderline Brenner tumor and what is a malignant Brenner tumor?
So in the histopathological features, in the cell nest, the malignant cells can be noted, ma'am. If the amount of malignant cell nest are few, then it will be borderline. If it's more than 50%, it is called as malignant Brenner tumor, ma'am.
Okay, so what you have missed is whether or not there is stromal invasion. Okay, so when there is cellular features of malignancy like altered nuclear cytoplasmic ratio and without any stromal invasion, you call it borderline Brenner tumor. You call it malignant when there is a stromal invasion along with features of malignancy in the cells. Okay,
Okay,
so
ma'am.
any idea what is a frozen section?
Process section, in cases where the diagnosis is not clear, the surgeons will take a small piece of biopsy in a preservative. Then it will be sent for histopathological examination. They will immediately do the training and everything, cell preparation within 30 minutes, and they will give the finding. And based on the finding, the surgeon can proceed with the operation, ma'am.
Okay. Okay, Janani, I think that's it for you. And you have did really well. I didn't expect you to answer this much for a pre-final year student. So, congratulations.
Thank you, ma'am.
And they'll let you know the results later.
Thank you so much, ma'am.
Hopefully. Okay, bye.
Thank you, ma'am. Bye, ma'am.
Parvati, you can share your screen now and start.
Okay, ma'am. So, good evening, ma'am. Myself, Parvati. I'm a final year MBBS student. So, my patient is a 22-year-old female from Kozhikode, Kerala, and she's studied till degree. Her blood group is O positive. Her husband is a teacher. His blood group is also O positive. And she's a primary gravida. And on the date of examination, her gestational age is 32 weeks and 4 days. So, her presenting complaints were bleeding per vaginum since morning on the date of examination and lower abdominal pain. So she was apparently normal and she came for her regular antenatal checkup to the outpatient department, and from there, while she was waiting for her turn, she started bleeding per vaginum. It was sudden in onset and dark red color with clots, and it soaked her clothes. She was not wearing any pads at that time. Then, a few minutes later, she developed lower abdominal pain. It was sudden in onset, and then the pain progressively increased in the intensity. There was no history of any decreased fetal movements, any fall or trauma, giddiness, or loss of consciousness. So, coming to the history of the present pregnancy, so this was a spontaneous conception, and she was a booked case. And in the first trimester, folic acid tablets were taken, TD first dose was taken, dating scan was done at 6 weeks, and it was normal and corresponding to her gestational age. Then there was no history of any fever with rashes, burning pain during micturition, excessive vomiting, drug intake, radiation exposure, bleeding or spotting per vaginum in the first trimester. In the second trimester, quickening was felt at the 5th month, iron and calcium tablets was taken, second dose of TD was taken, anomaly scan then at 20 weeks was normal. There was no recording of raised BP or blood sugar, no history of any vaginal bleeding or leaking in the second trimester, no history of edema, headache, or visual disturbances. In the third trimester also, the fetal movements were well perceived, but at 28 weeks and 5 days of gestational age, she had an episode of leaking per vaginum, which was sudden in onset, and it was not associated with any abdominal pain or bleeding. So she was managed with expectant management. She was given magnesium sulfate, antibiotics, and corticosteroids. She was admitted for 10 days and then discharged on advice of complete bed rest. So coming to her menstrual history, her menarche was at 12 years. She had regular cycles with no history of any heavy menstrual bleeding or dysmenorrhea. She was married for 1 year. It was a non-consanguineous marriage. No history of any contraceptive use. In the past history, she does not have any other medical comorbidities. There's no history of any surgeries in the past or blood transfusions. She followed a mixed diet. There was normal appetite and sleep, normal bowel and bladder habits, and no history of any addictions. In the family, there was no history of any bleeding disorders, no history of chromosomal anomalies, birth defects, or twinning. So she belonged to an upper middle class family, that is class 2 according to the Kuppuswamy scale. So coming to the examination, the general examination, she was poorly built and nourished. She was conscious and oriented. She was underweight. Her BMI was 16.86. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. And her vitals were stable. Her pulse rate was 100 beats per minute with regular rhythm, volume, and character. Blood pressure was 120/70 millimeters of Hg in the right arm in left lateral position, and she was afebrile. Now coming to the obstetric examination. On inspection, the abdomen was longitudinally distended, the umbilicus was flat, there was linea nigra and stria gravitarum, no scars, sinuses, dilated veins, hernial orifices were normal. Now on palpation, her fundus corresponded to her gestational age of 32 weeks, but the uterus was tense and tender, so due to which we could not palpate the fetal parts. But on auscultation, the fetal heart sounds were heard in the left spino-umbilical line and the rate was 130 beats per minute. So summarizing, my patient is a 22-year-old primary gravida, gestational age of 32 weeks 4 days, with a history of preterm premature rupture of membranes, which was managed on expected management. Now presented with sudden onset bleeding per vaginum and lower abdominal pain. On examination, the vitals were stable, uterus was corresponding to a gestational age, but the uterus was tense and tented. The fetal heart sound was present, it was 130 beats per minute. So the probable diagnosis is antepartum hemorrhage, possibly a reveal type of abruptio placenta. The patient was stable, there was no complications, the patient was not in shock, fetal heart sounds was good. So she was managed with a USG was done immediately and placenta previa was ruled out. The USG revealed a marginal placental separation, and after that we did a pervaginal examination. The O's was open and there was uniformly blood-stained liquor. Two large bore IV cannulas were put. Blood was taken for investigations and cross matching. Investigations, her hemoglobin, hematocrit, platelet count, and the coagulation profile was found to be normal. The WBC count was slightly elevated, which might be due to the pregnancy. Then she was immediately shifted to the operation theatre. Antibiotics were given, and then an immediate lower section segment cesarean section was performed under spinal anesthesia. The baby cried soon after birth, but the weight was 1.735 kilogram. The liquor was candy and bloodstain. On intra-op, we found that there was 50 grams of clots in the uterine cavity. There was placental separation. The placenta and membranes were removed in toto. The uterus was contracted and retracted, and there was no cochlear changes. Post-operatively, she was admitted in the high dependency unit, and she was given antibiotics, paracetamol, tramadol, promethazine, and tranexamic acid. And baby, as was underweight, the baby was admitted in the neonatal ICU. So, thank you, ma'am.
So thank you, Parvati, for sticking to the time mainly and for the detailed presentation too. So we'll move on to the questions now. So
Okay.
yours is a case of antepartum hemorrhage at 32 weeks, right?
Yes,
So
ma'am.
can we start with the definition of antepartum hemorrhage?
Ma'am, after any hemorrhage from the genital tract after 24 weeks of gestation, before the
No.
onset of labor, can be
Okay.
called.
So what are the two main causes for antepartum hemorrhage?
Ma'am, it can be placenta previa or abruptio placenta.
Okay. So in your case, that is the reason why you ruled out placenta previa by an ultrasound before doing the pervaginal examination, right?
Yes,
Okay.
ma'am.
So what do you think is the cause for abruption in your case?
Ma'am, there was history of preterm premature rupture of membranes. So that is a
Okay.
risk factor for abruption.
Okay. So what are the other common causes for abruption?
The most common cause is hypertension. Then there can be bleeding disorders. Then there can be any history of trauma or fall. Then sudden decompression of the uterus, like in if there is multiple pregnancy and sudden decompression. Then there can be hyperhomocystinemia. Then other risk factors are smoking and cocaine use. Then previous pregnancy, if there is history of abruption. Uh,
Okay. So in your case, what was the grading of abruption or how do you classify the abruption?
According to the page classification, in my case, there is symptoms of abruption, but the mother is also stable and there is no fetal distress. So it is grade 2 of abruption.
Hmm. Can you come
Sorry,
again?
sorry, grade 1, ma'am. Grade 0 means there is asymptomatic. It is grade 1.
Yeah. Okay.
Sorry.
So yours is grade 1 because there is no evidence of fetal distress or there is no evidence of maternal complications.
Yes,
Okay,
ma'am.
so this is as per page classification. What is your classification of abruptio placenta?
In that, in grade 1, it is asymptomatic. We only find retroplacental clots after the placenta is separated. In grade 2, that is symptomatic, but the fetus is stable. In grade 3, the fetus is dead. And then the grade 3 is again classified into A and B. A, there is no coagulopathy, and in type B, there is coagulopathy.
Okay, so you mentioned something about cochlear changes in the intraoperative findings. You mentioned that there was no cochlear changes, right?
Yes.
So what do you mean by cochlear uterus?
The bleeding can go into the myometrium, and the uterus will show this. The uterus will be very tense, and it will not contract. Um,
Okay, so how will it look like?
the reddish and bluish patches. Mm.
Okay, so what is the management for cochlear uterus?
It is not an indication for hysterectomy. Then we can, as a, we can in the next pregnancy we can give more antenatal screening can be done more vigorously.
Cochlear uterus will resolve on its own. Okay, there is no need for any extra intervention needed. And as you said, it's not an indication for hysterectomy. So, was steroids given for your patient? Antenatal
Steroid,
corticosteroids, was it given?
yeah, ma'am. When she had the premature rupture of membrane, steroids was given at 28 weeks.
Okay, what was the corticosteroids that you gave?
We give betamethasone, 12 milligram, two doses, 24 hours apart.
Okay, so what is the major complication, maternal complications of abruption that you are expecting?
The patient can go into shock due to the hemorrhage. Then she can go into
Okay,
renal failure because hypovolemia can cause acute tubular necrosis. Then there can be
okay,
disseminated intravascular coagulation.
okay. What is the reason behind DIC
Um,
in
uh,
abruption?
the all the fibrinogen will be consumptive coagulopathy. So the fibrinogen levels will decrease, and it can cause disseminated intravascular coagulation.
So there is release of thromboplastin, which in turn triggers the coagulation cascade, resulting in consumption of the clotting factors.
Yes, ma'am.
So resulting in DIC, right?
Yes,
Okay. So when she presented initially at 28 weeks with PPROM,
yes, ma'am.
why was MAG self given?
To give neuroprotection, we
Okay.
give
So
it.
what is the dosage?
Um,
Where else do you use MAG self?
in
In
case of
obstetrics? Okay.
preeclampsia,
What is the dosage there?
um, we give first loading dose, and then we give the maintenance dose. We give 2 grams IM as the loading dose.
Okay.
Then followed by I'm not,
I guess you didn't read the dosage. What is the regimen called?
we can use the KCOG regimen. KCOG regimen.
What is Pritchard's regimen?
Mm, I'm not sure.
What is Dispan technique? No idea. Okay, why was LSS done in your case?
The bleeding was continuing. It could not be stopped, so the patient can go into shock. So immediately LSCS was done.
Okay, when will you wait for a vaginal delivery in case of abruption?
If there is no emergency, like there is no fetal distress, the maternal conditions are also stable. If we could wait. Then also if there is the maternal condition is stable and the fetus is dead, then also we go for vaginal delivery.
Okay, not just that. Even in case of an IUD, if there is hypotension and shock, and you are suspecting that she will soon go in for DIC, you have to choose a LSCS as the mode of delivery. Okay, because you cannot afford to let the patient go in for DIC and renal failure, which is the two major complications that you are expecting here. Okay, so I
Okay.
think that's it for you, Parvati. Thank you for the presentation.
Thank you, ma'am.
Hello, hello.
Yeah, we can hear you, Joseph.
Okay, ma'am, is my screen visible?
Yeah, Joseph, you can proceed.
Okay, okay. If there is any problem with my audio, please do mention. So I'm Joseph Tommy. One good evening to all joined here. I'm final MBA student at Government Medical College, Kozhikode. Today I'd like to present the case on gestational trophoblastic neoplasia. So my patient is a 31-year-old lab technician hailing from Malappuram. Blood group is O positive. Para 2 living to with a history of a vesicular mole. Her last menstrual period was on the 9th of June. She was admitted on the 29th of August and examined on the 3rd of September. Her husband is a 34-year-old daily wage worker, and her social economic status is a lower middle class according to the modified Swami scale. First complaints, she is a known case of a gestational trophoblastic neoplasia who was treated with 7 cycles of chemotherapy of methotrexate, and she was admitted now in view of a rising serum beta HCG. History of present illness. The patient had a history of a missed abortion at 2.5 months of period of gestation in the August 2022, which was medically managed and was asymptomatic, which was not associated with any menses or bleeding for 3 months. After 3 months, she developed heavy bleeding with passage of clots and lower abdominal pain. A serum beta HCG was taken, which showed a 2 lakh million international units per ml, and an ultrasound showed retained products of conception, for which she underwent a dilatation and evacuation in December 2022. The patient was put on beta HCG follow-up and advised contraception. Beta HCG was initially falling and later showed a rising pattern. With these complaints, she was referred to Government Medical College, Kozhikode, and she was diagnosed as a case of gestational trophoblastic neoplasia, following which 7 cycles of single-dose methotrexate with folinic acid rescue regimen was given from December to March. Serum HCG follow-up was taken, and it showed an increasing pattern after chemotherapy. An ultrasound was taken, which revealed a persisting molar pregnancy, for which suction and evacuation was done in July to rule out an invasive mole. And the histopathology report showed an area stellar reaction with no chorionic or trophoblastic tissue. She was kept on beta HCG follow-up again, and it showed a rising pattern. She did not have any symptoms of fainting from dizziness. There's no history of fever, hypertension, hyperemesis, or hyperthyroidism. No cough, hematitis, chest pain, or dyspnea. There is no history of jaundice or epigastric. Coming to menstrual history, she attained menarche at 13 years of age and had past cycles were regular. Marital history, she is married for 10 years and is a non-consanguineous marriage. Sexual history, she has 2 children, both of them are full-time vaginal delivery. First one being 7 years old and the second is a female, 4 years of age. There are no history of any antenatal, intrapartum or postpartum complications. Children attain normal developmental milestones and are immunized up to age. Past history, she is not having any comorbidities and diabetes, hypertension, thyroid, or asthma, and no history of any past surgeries. Family history, she does not have any history of complaints in the family or no gynecological malignancies. Personal history, she has a mixed diet, normal sleep and appetite, and with regular bowel and bladder habits and no addictions. Summarizing, a 31-year-old para 2 living to with one history of vesicular mole who is a non-case of gestation of plastic neoplasia, completed 7 cycles of single-dose methotrexate and folinic acid rescue regimen, who was put on serum beta HCG follow-up, now showed rising pattern and a suction evacuation done on July. Again, beta HCG is still rising, suggestive of a relapse of gestational trophoblastic neoplasia with no signs of metastasis. General physical examination, she is conscious and oriented, moderately built, has a BMI of 18. There is no pallor into the sinuses, clubbing, retinopathy, or edema. Skin hair and nerves are normal. Breast, thyroid, and spine are normal. Her vitals, a pulse of 90, a BP of 110 per 70 millimeters of mercury, and respiratory rate of 18 per minute, and temperature, she was clinically right. Other system examinations were within normal limits. And moving on to gynecological examination, on inspection, the abdomen is flat, umbilicus central, no dilated veins or scars, perineal orifice intact, and all quadrants move equally with respiration. On palpation, there is no local rise of temperature, no tenderness, her abdomen is soft and no organomegaly, and the uterus is not palpable, and on auscultation, normal bowel sounds are observed. On local examinations, no suburethral nodules were observed and per speculum. The cervix is long and nose closed. On bimanual pelvic examination, uterus is anteverted, normal size and fornix is free. So a provisional diagnosis would be a 31-year-old para 2 living to with one vesicular mole who is a non with no signs of metastasis, initially treated with methotrexate, now presents with relapse 2 lakh, and post evacuation it reduced to around 1.5 lakhs, and by December 5th it came to around 3,000. But after that, it showed a rising pattern over 4 weeks. And it was with this we diagnosed it as a case of GTN and started on chemotherapy on the 3rd of December. After the first dose itself, she showed a very good response and showed a drastic decrease in beta HCG. Uh, on further follow-up, she was completed 7 cycles till March 18, the last 3 cycles being a consolidation cycle. But after further follow-up on the 9th of July, she developed further rise of beta HCG and ultrasound was taken and suction evacuation done on the 18th of July. But even after that, the beta HCG kept on rising. This was the criteria with which we diagnosed gestation trophoblastic neoplasia. And other routine investigation, her serology was negative and all other examinations were within normal limits. CBC, LFT, RFT, and URE, total protein and albumin, all were within normals. A TFT was normal. A baseline chest X-ray was taken, which was normal, and a CT test was also done, which was normal. The USG abdomen was taken on 18, which showed a retroverted uterus, endometrial thickening of 13 millimeters, and an endomyometrial junction with ill-defined in the fundal part and anterior wall of the uterus. Ovaries appeared normal. An MRI pelvis was taken and which showed a nodular enhancing lesion of size 13 into 9 millimeters in the upper uterus towards the fornices at the endomyometrial junction. This is the scoring system which we use to score the case of GTN. Includes age, antecedent pregnancy, pre-treatment HCG value, size of tumor, size of metastasis. And with this, we scored the patient, and the score was around 8, which made anything above 7 makes it a high risk case. So, in case of a high risk case, we can either go for a multi-management chemotherapy with weekly monitoring of HCG. In case of chemo-resistant cases, surgery or radiation is selected, and we monitor based on the response of beta HCG. And one of the common multi-drug regimen is the IMACO regime, consisting of etoposide, methotrexate, actinomycin, cyclophosphamide, and vincristine, which could be given to the patient as a mode of treatment. Thank you.
Okay, sir. Okay, Joseph. So you told me that it is a case of gestational trophoblastic neoplasia, right? So what is the
Yes.
staging of gestational trophoblastic neoplasia?
Staging, the WHO staging is staged as 4. Stage 1, the disease is confined to the uterus. In stage 2, the disease can extend to the pelvis. In stage 3, there is lung metastasis with or without pelvic involvement. And in stage 4, there is distant metastasis.
Okay. So your case is just stage 1, right?
Yeah, it is, yes, stage 1, confined
So
to the uterus.
usually stage 1 GTN comes as
Yes.
low risk. What makes your case as a high risk GTN?
The WHO, according to the WHO scoring system, she has a score of 8 currently.
That is, she has a previous failed chemotherapy, which puts her at high risk. That is what is making the scoring to be more than 7. Okay.
Yes.
So, how was the methotrexate given? What was the regimen followed and the dosage?
It was a single dose regimen given. The dose is 1 milligram per kilogram, given in alternate days, and each successive day is followed by a folinic acid given as 0.1 milligram per kilogram, given over 2 weeks.
Okay. So, what is the mechanism of action of methotrexate? How does it work?
Methotrexate is a folic acid antagonist. It inhibits cell multiplication, basically. It inhibits DNA synthesis.
What is the enzyme that is inhibited by methotrexate?
Folate reductase.
Okay, so folate reductase or folic acid reductase is the enzyme that is inhibited. Okay, so how will you monitor a patient for methotrexate toxicity? What are the things you'll look for in blood investigations?
Methotrexate toxicity, the WBC level should be monitored. It can bone marrow suppression is a side effect of methotrexate. All pancytopenia can be there. My patient developed
leukopenia.
Yeah, and for which she was administered filgrastim also after the first dose of methotrexate.
Okay, fine. So, what is the plan now? for your patient,
Uh,
since she has
uh,
already has failed chemotherapy with a single agent?
yeah, either we could try to substitute the chemotherapy agent. We can either try giving an actinomycin B therapy or go
Okay.
for a multi-drug regimen. But and also she's now 31 years and has two children. If she doesn't want to have a child further, if the family is completed, we can give her a hysterectomy.
Okay. So, what do you think is the role of hysterectomy in gestational trophoblastic neoplasia per se?
Yeah. There are certain conditions which are chemo resistant,
Okay.
and if there is intractable bleeding, or in conditions such as the placental site trophoblastic tumor and the epithelioid trophoblastic tumor, uh, hysterectomy is the definitive mode of management since they are not amenable to drug therapy, chemotherapy.
Okay. So, what is placental site trophoblastic tumor?
Placental site, it is a tumor which develops from the intermediate trophoblast,
Okay.
which is
So, as
uh,
you said, it doesn't respond well to chemo. Okay. So, what is the tumor marker? What raises in placental site trophoblastic tumor?
it's not beta HCG. It is
Yeah,
not
that's
sure.
why I asked you the question. Because
Not
it's not
yes,
beta HCG.
not sure.
Okay, fine. So, what is epithelioid trophoblastic tumor?
It is also another variety. It's also uh,
Where does it arise from? Which cells?
epithelioid cell.
Okay, so it arises from the syncytial trophoblastic. Okay, one more
Oh,
question. Your case was a gestational trophoblastic neoplasia following an abortion, right? An abortion
following
that
an
was medically
abortion
managed.
at 2.5 months. Yes.
Yeah. Okay. So there is no histopathology proven diagnosis for you to say it is a
Yeah,
molar pregnancy. Is
it's,
there?
I could not find the uh, histopathology report because she was not at our hospital. She was referred here, and they did not have a histopathology report showing a diagnosis.
Okay.
But
I also saw that you have mentioned the pre-treatment beta HCG at 2600. Was it
no,
right?
2
Why
lakhs.
was
It's
it
a
done?
pre-treatment. After the evacuation of the first abortion, she was kept on follow-up. That showed a beta
Um,
HCG.
you don't normally do that for an abortion, right? For an
I don't
abortion
know.
that is medically
Uh,
managed. Yeah. Then
no,
why?
don't.
Why was it done?
Uh, uh, but she developed excessive bleeding after 3 months of that abortion, and it was at that time they took a beta
Actually, I remember. Okay, I remember you mentioning that the abortion was in August 2022, and
Yes,
she did not have any complaints or bleeding for 4 months, and only
for three.
during December she had bleeding.
After yes,
Yeah,
after three.
during
After
December the beta CG value was 2 lakhs, right?
yes.
Yeah. So when is this 2600 coming into the picture?
Just a minute. No, I don't. 2,600. I think it's 2 lakh.
Oh, maybe it was a mistake on your
Yeah,
abstract then.
graph.
I
Yeah,
remember seeing 2600.
2,000.
Okay.
2 lakhs.
Okay. On to the next thing then. So you mentioned chassis by doing a CT chest, right?
Yes, ma'am.
What else should you be doing actually?
Metastasis can most commonly involve chest, lungs, for which we can take an X-ray, CT chest. A brain
Okay.
MRI can be taken to rule out brain
Oh,
metastasis. An
okay.
abdomen, CT abdomen should be taken to rule out
Okay.
liver metastasis, spleen metastasis, and vagina should be inspected for local metastasis.
Okay. 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 So was CT abdomen done?
No, CT abdomen was not done.
So you have
And
just done a CT chest only, right?
yes.
Okay.
And
So
ultrasound.
okay. So, and you mentioned something about the histopathology report of the suction evacuation done in July
Yeah.
2023. You said that
Yes.
you are trying to prove that it is an invasive mole by doing
Yes.
suction evacuation in the histopathology, but you are not
Yes.
able to find any evidence of trophoblastic tissue, right?
Yes.
So, do you think invasive mole can be proven by a suction evacuation and an histopathology report? Is that the investigation of choice?
Um, so, it should be of the genotype. I'm not sure.
So actually, invasive mole cannot be proven by histopathology. That is the reason. You will not find trophoblastic tissue in the curate or in the suction that you do. Okay, so most of the times it is only a imaging diagnosis, like how your MRI showed a nodule in the endomyometrial junction. That is what you will find. You will not be able to prove it histopathologically. So that is one thing. Okay, so
Okay.
what is the multi-agent chemotherapy that you can try for this patient?
The macro regime
Okay,
consisting
you
of
can put her
uh,
on IMACO regimen. Okay. So what was done for your patient actually?
actually our patient was started on actinomycin B pulse therapy,
Oh, okay.
1.25 milligram per meter square.
Okay. So she is responding well to actinomycin as of now.
Yes, I was only there for 1 week after I took the case, and now I changed the department. Yeah, for our first dose, she was responding very well.
Okay.
Decrease in the HCG level was seen.
Okay. Okay. So how long do you think she should be monitored after
She
the
should at
chemo?
least be monitored for 1 year.
Yeah, at least
She should.
12 negative values every month. Okay, as you said, for at least for a year after the chemo, she has to be monitored. Okay, so what is the treatment option for metastatic disease?
Depends upon the site of metastasis. If it is lung metastasis, it involves pulmonary wedge dissection. If it is brain,
Okay,
it can be irradiation, brain irradiation. If it is lung,
okay,
it is liver. It is hepatic resection or intraarterial chemotherapy agents can be given.
okay.
Then
Local mets to the vagina.
vagina, it can cause vaginal bleeding or suburethral nodules, which can be removed and
Okay,
bleed be packed properly.
okay, okay. So how does folinic acid help while giving methotrexate?
Uh, Folic acid replenishes the folic acid level, which is
So
blocked
it is
by.
not affected by the folic acid reductase enzyme. It doesn't need that.
Uh,
So it can work well without the folic acid reductase
and,
enzyme, and it will help in the cell proliferation. That is the DNA and the RNA synthesis. Okay. Um, okay. What is the dosage of folinic acid if you're going to give it orally?
is it zero point 0.1 milligram per kilogram? That is
Okay.
usual.
You do give it every alternate day, right? What is
Yes.
the other methotrexate regimens that you know of, apart from the one that you mentioned for your patient?
This is a single dose duration. Then this given in, not sure when I can't recollect.
Okay, it's okay. Thank you, Joseph. It was a detailed presentation and you answered very well. Thank you.
Thank you, ma'am.
Hello.
You're audible, Roshan. You can share your screen and start.
Okay, ma'am, I'll start. Hello.
Yeah, you can start.
All right, ma'am. Thank you. So here I am to present an interesting case where I've given it a name called benign masks malignant. A benign condition masking a lot of things about another malignant condition. We'll see what it is. So the history, it's a 70-year-old female who came with complaints of abdominal distension. It was insidious in onset for 3-month duration, and it progressed from a very small size to the current size. And she had abdominal pain, which was dragging type for the past 4 days, which was associated with constipation for the past 2 days. Her obstetric, her parity index is para 3, light 3, with a history of hysterectomy. So the hysterectomy was done 15 years back, and the cause or the reason why the hysterectomy was done was not known. And on examination, the patient had a tender palpable mass which measured about 25 into 20 centimeters, which occupied all the quadrants of the abdomen, with the lower border not palpable, and it corresponded to about 32 weeks of gestation, about 8 centimeters above the umbilicus. And on percussion, a dull note was heard over the mass, and there was no fluid thrill or shifting dullness. On pervaginal examination, a mass was felt in the pouch of Douglas through the vault, which was bimanually palpable as well as movable. On perrectal examination, there was no abnormality detected. So with this findings, whatever from history as well as the examination, we came to a provisional diagnosis of an abdominal mass for further evaluation and management. Based on the pervaginal examination findings, we came to a provisional diagnosis of an adnexal mass involving the ovary. So investigations, we proceeded on with the ultrasound. It showed us a 10 into 10 lesion in the lower pole of the right kidney. We were suspicious of an adnexal mass, but ultrasound revealed something more, and it also showed a right ovarian dermoid with torsion measuring about 20 into 19 centimeters. Before I move on to the CCT, CA125 was found, and it was found to be around 143 on the higher side. And CECT findings are these: there is a heterogeneously enhancing mass, which was contrast enhancing mass, which was found in the middle and the lower pole of the right kidney, along with which we were also able to see a well-defined heterogeneous mass with surrounding fat stranding and whirlpool sign being positive, indicating that the ovarian dermoid, as the radiologist said, was present with torsion. So this was the impression. Right renal cell carcinoma, we were able to tell it as renal cell carcinoma based on the Bosniak grading that the radiologist does, involving the middle and the lower pole of the kidney with a right ovarian dermoid with torsion. So this was the impression that the radiologist gave, and we proceeded on with the right radical nephrectomy and a staging laparotomy. Intraoperatively, yes, we were able to find the ovarian tumor being adherent to the mesentery, and it was rotated 360 degrees around its own axis, likely indicating that the ovary has gone for torsion. It was a post-hysterectomy status, as the patient told, and the left ovary was not seen, and no ascites, no subdiaphragmatic deposits, and it was a normal liver. And right kidney, yes, there was a mass in the middle and the lower pole. So this was what we did, and interesting part came with histopathology. Before that, this is the image of the surgery before the right radical nephrectomy and after the right radical nephrectomy. And gross images of the ovary showed that there was foci of degeneration as well as necrosis. On cut sections, we were able to see a white to tan colored whorled pattern. Yes, it did ring a bell, and there was firm bulging pattern also seen, which was yellow in color. That also likely indicating adipose tissue. Radiologist said it was a dermoid. We went on with the HPE. Before that, the kidney specimen, yes, there was a foci of necrosis and hemorrhage involving the middle and the lower pole of the kidney, and the tumor was not involving the renal pelvis. The nodal status of this patient, all the nodes were showing follicular hyperplasia, but there was no tumor cells in the nodes. So kidney, yes, the kidney showed a clear cell carcinoma of the kidney with a Fuhrman grading of grade 2. Interestingly, the tumor was limited just to the kidney. Renal pelvis, even the renal pelvis was not involved, and tumor necrosis and lymphovascular invasion was not identified, pointing to a pathological status of P2A. And here we can see the normal renal tissue as well as the clear cell component. On 40x microscopy, we can clearly see the clear cell carcinoma of the kidney. The most interesting part of this is the ovarian malignancy that we saw. I mean, the ovarian lesion, which was not an ovarian dermoid, rather it was an ovarian lipoleiomyoma, because the ovary showed spindle-shaped cells with a lot of adipose tissue distributed between them. And we just can't say ovarian lipoleiomyoma just like that based on the gross images and the H&E. We had to do a immunohistochemical analysis. We did a Desmond stain, which was specific for smooth muscles, and it came out to be positive, pointing to an interesting diagnosis of a benign condition of an ovary, ovarian lipoleiomyoma. So this has been reported in various articles in British literature, and ovarian lipoleiomyoma here in my case has masked the features of a malignant condition that we are dealing with here, which is the renal cell carcinoma. Interestingly, the patient didn't have hematuria, so we were not having an idea of the renal cell carcinoma. Of course, the tumor of the kidney didn't involve the pelvis, thereby there was no hematuria. And on the discussion part, yes, it is a very rare entity, and these microscopic features are similar to leiomyoma of the uterus, and it had adipose tissue in addition to it. So a differential diagnosis that I'd like to give is, rather syndromes. Various syndromes are being associated with renal cell carcinoma and various other things. Here, one specific thing I'd like to discuss here is hereditary leiomyomatosis and renal cell carcinoma, which says papillary renal cell carcinoma is associated with leiomyomas of the uterus. So if I'm able to say that, here in my case, it's a clear cell carcinoma, and there is a genetic mutation of a fumarase gene in hereditary leiomyomatosis with renal cell carcinoma. So if I'm able to say that this fumarase gene is mutated in our patient, I can also say that clear cell carcinoma might also present with leiomyomas of the uterus, but of course we have an ovarian lipoleiomyoma here, so that's a bit of something which is scope for further improvement. And here is a case of a benign ovarian lipoleiomyoma masking a malignant renal cell carcinoma on examination, or rather the benign ovarian lipoleiomyoma helping the patient present early to our department, thereby saving this patient from a malignant renal cell carcinoma. Rather, the benign lesion saving the patient from a very deadly malignant condition, that is renal cell carcinoma. So don't trust benign lesions, and early radiological investigations and intervention actually helped us to understand about the renal cell carcinoma, and the multidisciplinary understanding of histopathology and serological investigations has helped us understand about this rare entity of an ovarian lipoleiomyoma masking a clear cell renal cell carcinoma. Thank you.
So, Roshan, that was a really good presentation.
Thank you.
So, as you said, it might be a syndrome too.
Yes, ma'am.
We don't know the cause for the hysterectomy also, right? We don't know the reason behind the hysterectomy. That might have been benign leiomyoma too.
The thing is, she didn't have a abdominal scar anywhere in her body, ma'am. So it was probably a vaginal hysterectomy, ma'am.
Okay.
Yeah,
maybe it might have been for a pelvic organ prolapse, or it might have been a non-descent vaginal hysterectomy for a benign leiomyoma. You never know.
Yes,
in which case, it might prove your syndrome too, right? Hereditary leiomyomatosis along with the renal cell carcinoma. Okay, so moving on to the discussion part. So as you mentioned, there was no hematuria, right?
Yes.
So what do you think is the triad of symptoms in renal cell carcinoma?
So the triad is loin pain, palpable abdominal mass, and hematuria.
Okay, so in your case, there was no hematuria. So you were only investigating for an abdominal mass. Okay, so
Yes.
which in turn pointed towards the renal cell carcinoma. So in your abstract, you mentioned the RMI scoring, right?
Yes,
So
ma'am.
what was
Yes.
the RMI scoring for your patient?
Ma'am, it was greater than 250, ma'am. So it
Okay,
was, we had a suspicion of an ovarian malignancy, but of course there was no ascites in our patient. So we,
okay.
and as the radiologist told it was a dermoid, we proceeded on just like that, ma'am.
Okay, so there was no evidence of any metastasis in form of ascites or
Yes,
the characteristics of the cyst. So you were going in terms of a benign mass, even if the
yes,
RMI scoring was more than 200.
yes,
Right.
ma'am.
So
True.
did the ultrasound show any malignant features? So
Uh,
how do you calculate the RMI score? So what are the
so
ultrasound features that you take into account?
So the locularity of the lesion, the solid or cystic, the solidarity, the metastasis, bilaterality, and ascites, ma'am. These five
Okay, so
features, yeah.
okay, you
And if it
assign
is a
one.
premenopausal woman, it's one, and postmenopausal, it's three. So we
Okay.
multiply these into the CA 125 value that we have.
Okay. So what is the normal CA 125 levels?
It's less than 30, ma'am.
Okay. So how is it in reproductive age group?
Yes, ma'am. There is a slight elevation in CA 125.
Okay. So in reproductive age group, CA 125 of even 200 is acceptable in
Subsequent.
benign conditions like fibroid or endometriosis. But since
Yes.
your patient is a 70-year-old post-hysterectomy patient,
Yes, ma'am.
any value more than 35 is significant, and yours was 143.
143.
Okay. Okay. So you mentioned that there was evidence of torsion in the imaging, right?
Yes,
So,
ma'am.
how do you think a patient with torsion will present usually, clinically?
Usually, patient is likely to present with an acute abdominal pain, ma'am. Uh,
Yeah.
but the patient had pain for 4 days, so we had a little bit of a suspicion for torsion. But after
Okay.
the investigations, we were able to know that it was a torsion, and immediately we proceeded with a elective surgery, ma'am.
Okay. So, you mentioned whirlpool sign in the imaging, right? So, what do you think is the investigation of choice actually to diagnose torsion in a huge ovarian cyst? Do you straight away go for a CT or an MRI, or what do you do?
As in, I don't get you, ma'am. Investigations as in or examination findings.
Okay, we'll start with the examination finding then. What will you see in examination?
So we will be able to see a tender palpable mass, ma'am.
Okay.
Yes, ma'am.
So if you
And
want to, okay, I'll rephrase my question. If you want to confirm the vascularity for a mass or a
yes, ma'am.
cyst, what will be your investigation of
I'll
choice?
do a Doppler ultrasound.
Okay, so that's what I was expecting from you. So an ultrasound with a Doppler which shows whether or not there is a peripheral vascularity in your lesion.
Yes,
That will tell you better whether there is torsion or not. But since the patient was not presenting with an acute abdominal pain with a tachycardia or guarding or tenderness, you were not thinking in terms of torsion. That is my opinion actually, which made you to go for an MRI later, which showed evidence of torsion. But
yes,
okay,
ma'am.
so we were discussing about RMI scoring, right? So what
Yes,
is
ma'am.
Roma scoring?
Risk of malignancy uh, assessment, ma'am.
It's risk of ovarian malignancy algorithm actually. So what
Algorithm.
do you take into account in Roma scoring?
We also take into account transvaginal ultrasound features,
Okay, and then
transabdominal ultrasound, as well as obviously the CA 125 score.
you include the human epidermal protein 4 also. HE4 also will be
HE.
included in Roma scoring. Okay,
Okay.
so what is ROCA? ROCA.
ROCA, a cancer algorithm.
Okay, so what do you do in that?
In
What
that
is it
only, I
based
think
on?
we do the ultrasound transvaginal.
Ultrasound and serial CA 125 monitoring also, not just a single value. Okay, so let's just deviate a bit from your case now. What is a Krukenberg tumor?
Krukenberg's tumor is a metastatic tumor that has arisen either from the carcinoma of stomach, which is deposited as a secondary in ovary.
Okay, so what is the classical histopathological finding in a Crokenberg tumor?
Corneal nucleus, ma'am, signet ring appearance.
Okay. So, could did you think of possibility of metastasis or a Crokenberg tumor in your case, or why did you rule it out?
In the first place, patient, we didn't have a suspicion of malignancy at all, since the patient didn't have much of compression symptoms. All the other
Okay.
history were negative for a tumor, ma'am.
Okay. So Crokenberg tumor is not likely to arise secondary to a renal cell carcinoma in the
Yes.
first place. No? So it's until now you will not be getting a signet ring subtype of metastasis there, and it's more likely to be bilateral and not a unilateral huge mass as in your case, which rules out the possibility of it being a Crokenberg tumor. Okay. So you mentioned that you did a staging laparotomy, right?
Yes.
So what are the steps of staging laparotomy?
So first, after informing the procedure and getting consent from the patient,
Mm.
preoperative anesthetic assessment has to be done, and then
Mm.
in the theater, the patient is put in supine position with the parts painted and draped. A midline
Okay.
incision is put, and then
Sorry to stop you there. Did you mention the anesthesia?
yes, I didn't mention the anesthesia under spinal anesthesia, ma'am.
Actually, we prefer general anesthesia for staging laparotomy. So, under
Okay.
general anesthesia, using a midline vertical incision. And
Yes,
then,
ma'am.
what will be the
Uh,
next thing?
Yes, ma'am. We open the peritoneum. If the patient has ascites, we will be taking a sample of it. If not, we will be
Okay.
doing an ascitic wash with 50 ml of
Okay.
saline. And then
Okay.
we will be inspecting all the organs in a clockwise manner. So, starting from
Mm.
the cecum, ascending colon, transverse colon, descending colon, and all the other organs as well, like the liver and the spleen. And after that,
Okay.
we will be doing a transabdominal hysterectomy will be done with bilateral salpingo-oophorectomy. After
Okay.
doing that, we will be doing a infracolic omentectomy. In after
Okay.
after infracolic omentectomy, we will be doing a pelvic lymph node dissection. Uh,
Okay.
and after the
So,
pelvic,
in your case, you mentioned sending the peritoneal washing for cytology, right?
yes, ma'am, yes,
So, what was the cytology report?
it was negative for malignant cells, ma'am.
Okay, so it was negative for malignant cells. Okay, so why do you think they were suspecting dermoid as per the imaging finding?
Uh, Usually, it is the most common ovarian tumor presenting at this age, and also the radiological features were highly suggestive of
Okay,
thermoid.
okay, I'm going to stop you there. I don't think dermoid is the most common tumor that is presenting in a 70-year-old female. So
Okay, sorry,
epithelial
sorry, sorry.
tumors.
So, germ cell tumors are present in young age, young age.
So that is supposed to be seen in
Yes, ma'am.
reproductive age group, whereas your
Epithelial
patient is
tumors are
70-year-old. Epithelial tumors are more. But I'll agree with your second point where you said the imaging findings were consistent with a dermoid. That might be because the adipose tissue in the lipoleomyoma might have been a misleading factor, making them think that it might have been a dermoid. So, what do you think is the cause for torsion there?
uh, usually, I mean, we have already done a hysterectomy, ma'am, and one of the ovary was actually absent. So this ovary is just hanging around there, and due to the mass effect, it tends to coil around its own axis around the fallopian
Okay.
tube, thereby causing torsion, ma'am, which is a
Okay.
complication of an ovarian lesion.
Okay. So torsion actually is the most common complication that you see in a dermoid. And the reason they give is that the fat content in the dermoid makes it to float freely in the peritoneal cavity. So causing it, making it more prone for torsion. Though I agree with your point saying that she was a post-hysterectomy female, so this was a huge mass and it was floating freely. And
Yes,
I think you can give the same explanation for your case also. Like your lesion being a lipoleomyoma, the content that is adipose tissue also might have been the reason for it to have undergone torsion. So I think it's an interesting case overall. and you presented it very well. And the
Thank you.
discussion part also was very good. So, one final question before we move on to the next person. What is a neoadjuvant chemotherapy?
Usually for ovarian malignancies, we go on for platinum compounds like cisplatin, oxaliplatin, carboplatin, as well as taxanes like paclitaxel, doxataxel.
What is neoadjuvant?
Neoadjuvant chemotherapy is given to downstage a tumor. So chemotherapy is given pre-operatively for a specific duration so that the tumor is downstage.
Roshan, I'm going to stop you there. There is some network issue. 1 second. So,
Yes.
coming back to the question, you can say now.
Yes, ma'am. So neoadjuvant chemotherapy is chemotherapy that is given pre-operatively to downstage a
Mm.
disease. There is shrinking of the tumor as well as the vascularity of the tumor also decreases, thereby helping the surgeon to have a less vascular field and get better margins.
Okay, so it helps us to achieve optimal cytoreduction
Yes,
and giving us a relatively bloodless field, right? Okay. I think that's it, Roshan. Thank you.
thank you, ma'am.
Ma'am, is my PPT visible?
Yeah, we can see your screen. You can start presenting.
Okay, ma'am. Good evening. My name is Adrenergix, and I'm from Melmarupur Adiparashakti Institute of Medical Sciences and Research. I'm here to present a case on antenatal women. The history goes as Mrs. Maheshwari, a 27-year-old female hailing from Acharapakam, who has studied BE and is a housewife, a prima gravida, wife of Mr. Satish Kumar, 30 years, and a policeman, came to the hospital with chief complaints of elevated blood pressure levels. The history of plasmic illnesses, the patient was apparently normal before 8 days, after which, while attending normal checkup, was informed of high blood pressure levels and was admitted in the hospital for the same on 13/9/23. The patient did not have any imminent symptoms of elevated blood pressure such as headache, blurring of vision, vomiting, decreased urine output, epigastric pain. The present pregnancy history is first trimester. Her last menstrual period is on 5/1/23 and the expected date of delivery is October 12, 2023. The gestational age as on 20th September is 36 weeks and 6 days. The pregnancy was spontaneous and was confirmed by urine pregnancy test at home after 40 days of amenorrhea. The reading scan was done on March 10th with normal viable single intrauterine gestation of 8 weeks. Single gestational sac was seen, yolk sac was seen, and crown rump length of 1.8 centimeter with fetal heart rate of 178 per minute. Nuchal translucency scan was taken on April 11th. Single gestational sac was seen, but two fetal poles were identified, one active and one missed. Twin 1 corresponded to 13 weeks with NT 1.6, nuchal translucency 1.6 millimeter with fetal heart rate 147 beats per minute. The twin 2 was found to have anencephaly with no cardiac activity and it was declared as missed abortion of 10 to 11 weeks duration. Folic acid tablets were given. First dose of TD was given. She had a history of hyperemesis gravidarum but did not take treatment for the same. And no history of fever with rash, radiation exposure, burning micturition, drug intake, and spotting PV. Second trimester, quickening was felt only at 28 weeks, that is 7 months. Iron and folic acid tablets with calcium tablets were taken. Anomaly scan was taken on May 4th. Twin 1 was a single intrauterine growth with 17 weeks and 3 days. Placenta was common and anterior. No anomalies detected. Twin 1 was the pump twin and twin 2 was the perfused twin. Twin 1 has a fetal heart rate of 138 beats per minute. Twin 2 had absent cardiac activity, rudimentary lower limbs. Second trimester scan was also taken, which was on June 14, and twin one had an age of 22 weeks plus 6 days. Cardiac activity was present. Placenta was common and anterior. Maternal Doppler showed an increase in uteroplacental resistance. Fetal Doppler was normal. And twin 2 was a perfused twin, acardiac, acephalic, avascular, and amorphic fetus. Oral glucose tolerance was done and was found to be normal. Second dose of TD immunization was given. No history of burning micturition, bleeding PV, abdominal PV, white discharge PV. No history of headache, blurring of vision, vomiting, decreased urine output, or epigastric pain. Third trimester, the mother continued to perceive fetal movements. Intake of iron, folic acid, and calcium tablets were present. No history of burning micturition, bleeding PV, abdominal PV, or white discharge. No history of headache, blurring of vision, vomiting, decreased urine output, or epigastric pain. Growth scan was taken on August 18. Twin 1, single live intrauterine growth with 37 weeks and 5 days. Fetal heart rate was 144 beats per minute. Cephalic presentation was seen. Placenta was common and anterior. And maternal Doppler showed increased uteroplacental resistance with fetal normal. Fetal Doppler normal. Perfused chin was avascular with no cardiac activity. Moving on to the contraceptive history, she had no significant history of usage of contraceptives. Menstrual history, she attained menarche at 15 years with regular cycles of duration 5 days and interval 28 days, not associated with pain or passage of clots. Marital history, the patient was married at 26 years and it was a non-consanguineous marriage. Past obstetric history, no significant past obstetric history, no significant past history such as diabetes, hypertension, tuberculosis, asthma, epilepsy or thyroid issues and cardiac issues. No history of any blood transfusions or drug allergies. The treatment history, no significant past medical or surgical history. Family history, no significant family history. Moving on to the personal history, mixed diet, normal appetite, normal bowel and bladder habits, normal sleep cycle, no history of smoking, alcohol or drug usage. Moving on to the examination, the consent was obtained from the patient and for examination, the patient was moderately built, nourished, cooperative and oriented to time, place and person. No pallor, icterus, cyanosis, clubbing or lymphadenopathy or pedal edema seen. Height of the patient is 160 cm, weight is 85 kg. Weight gain during pregnancy is 9 kg. Breast and thyroid examination was normal. Vitals, pulse was 86 beats per minute. She was afebrile with BP of 140-90 mm was mercury. A respiratory rate of 16 per minute. Obstetric examination. On inspection, abdomen was fully distended, flank full, linea nigra and striate gravidarum were present. Umbilicus was in the midline and inverted. No visible dilated sinuses, scars or engorged veins. Palpation, no warmth or tenderness present. Fundal height corresponded to 36 weeks. Fundal drift, soft, broad, irregular and not independently ballotable, indicating the presence of breach. Lateral grip, uniform, convex resistance felt, indicating the presence of spine on the left side. Small irregular parts on the opposite side, that is right side, spine indicating limbs. First pelvic grip, hard, round, compact and ballotable independent of body, indicating the presence of head. Second pelvic grip, converging hands and it indicated that it was not engaged. Auscultation, fetal heart sound heard at the right side of the umbilicus with a fetal heart rate of 150 beats per minute. Other systemic examination, CVS, S1, S2 heard with no murmurs. RS, bilateral normal vesicular breath sounds heard with no added sounds. CNS, no focal neurological deficits. Summary, Mrs. Maheshwari, 27-year-old female and a housewife hailing from Acharapakam, is a primary gravida, booked an immunized case. Last menstrual period, January 5, and expected date of delivery, October 12, was admitted was elevated blood pressure levels with single live fetus, and she has a history of monochorionic diamniotic twins with only one viable fetus with no other complications. Moving on to the investigations, the patient was done on complete blood count, urine routine, urine culture and sensitivity, renal function test and liver function test, and all the reports were normal. The management taken was, she was monitored for low-lying placenta and daily fetal movements were counted. Normal diet was advised, adequate hydration was advised. The patient was initially started on labetalol with a BD dose of 100 mg, then followed by 3 days dose because it was not until control. Then further, we have We monitored her and we gave labetalol TDS 200 mg for at morning and night with 100 mg at the afternoon. She was also given for nitrofurantoin 100 mg, pantoprazole 40 mg, ferrous sulfate 100 mg, calcium 500 mg, and she was advised for BP charting and non-stress test BD, and she was advised to inform any problem on SOS. This is the non-alive twin after she delivered. Thank you. Thank you.
Okay, Abhirami. So before moving on to the discussion, uh, you said the management part, no?
Yes,
LLP
ma'am.
stands for left lateral position. Okay,
Okay, ma'am.
and it's not low lying placenta here. Okay, now
Yes,
we'll
ma'am.
start with the questions. So yours is a case of twin pregnancy, right?
Yes, ma'am.
Monochorionic diamniotic twin. That is what I
Yes, ma'am.
understood from what you said. Right.
Yes,
So
ma'am.
is it a trap sequence?
Yes, ma'am. It was a
What?
trap.
Okay. So what was the management for the trap sequence done then? Actually, the yours is not a typical presentation of trap, right?
Yes,
So
ma'am.
how should a pump twin and a perfused twin, how will it present in a typical trap?
Mm.
What will be the
In the
ultrasound features in a pump twin?
pump twin, the placenta will be larger for the pump twin, ma'am,
Okay.
and the perfused twin will have a smaller placenta.
Hmm?
We can identify it in the ultrasound, ma'am.
Okay. Other than that,
Uh,
there will be features of hydrops, polyhydramnios, and cardiac
yes, ma'am.
failure in the pump twin. Since it is going
Yes,
to be
ma'am.
pumping for both the acardiac twin as well, there will be cardiac failure features in the pump twin. Okay.
Yes, ma'am.
So you said it's a monozygotic diamniotic pregnancy. Yeah.
Yes, ma'am. Yes,
So
ma'am.
what is a monozygotic twin and what is a dizygotic twin?
Ma'am, monozygotic twin, it comes from the fertilization of one sperm with one ova, but it will get divided into two, ma'am. But in
Okay.
dizygotic, two sperms will fertilize one ova, ma'am.
No, no, it is two sperms fertilizing two separate ovumes. That is
Yes,
why it
ma'am.
is dizygotic. And
Yes, ma'am.
monozygotic, you are right. So it is a single sperm fertilizing a single ovum. After the formation of zygote, it is going to be split into two. Okay.
Yes, ma'am.
So
Yes, ma'am.
uh, how does a monozygotic twin divide? So depending upon the time of division, you will have different chorionicity and amnionicity, right? So if it divides within 3 days, what will be the end result?
If it divides within 3 days, it would be diamniotic, ma'am.
Diamniotic, okay. Within
Yes,
4
ma'am.
to
And
7 days,
4 to 7 days, it may change into monoamniotic because the time for division of the amnion is not given.
okay. So what happens if it divides after the 8th day?
The it will be dichorionic. That is, placenta can be split, but the amniotic sac cannot be split. So the both the fetus will grow in the same amniotic presentation.
Okay. So when you have a single amniotic sac, a monoamniotic sac, what are the specific complications that you expect?
One twin may be perfused more than another twin, ma'am. The blood supply will not be equal, and
Okay.
the growth restriction may occur in any one of the fetus due to stress. And if it is
Okay.
associated with any comorbidities such as the hypertension, as we had in this patient, uh, it will also add to the stress of circulation to the fetuses, and the maternal body will not be able to give enough nutrients to both the twins equally.
Okay. So These are the things that you can expect in a dizygotic twin also, right? So what
Yes,
is
ma'am.
specific complication in a monochorionic monoamniotic pregnancy? Like your trap, what else can you expect? What are the syndromes? What is twin to twin transfusion syndrome? And what is twin anemia polycythemia sequence?
Ma'am, twin-to-twin transmission syndrome is rather than both the twins acquiring blood from the maternal body, one twin will pump the blood to another twin.
Okay.
Basically, it will be supplying the another twin and trying to make it alive. But
Okay. So what
as the
is
time
what is the vascular anastomosis that you see in TTTS? It is an
um,
arteriovenous anastomosis. Okay, so as a result of which one twin is becoming the donor twin and the other is becoming the recipient twin. Okay, so whereas in case of trap, the anastomosis is between two large placental arteries,
yes,
whereas in
ma'am.
TTTS it is between an artery and a
At the
vein.
end of it.
Okay. Okay. So, what is the ideal time to determine the chorionicity in a twin pregnancy?
Ma'am, during NT scan we can see it
Okay. So, in the first
clearly.
trimester, doing a transvaginal ultrasound will be the ideal time in the first trimester to determine the chorionicity. Okay.
Yes,
So, what
ma'am.
is a lambda sign and what is T sign? Lambda sign or twin peak sign? Okay, so lambda sign or twin peak sign is what you see in dichorionic diamniotic pregnancies. Okay, that is
Yes,
in
ma'am.
between the two amniotic sacs, you will see a triangular projection of placenta, which will give you the appearance of the sign lambda. So you call it the lambda sign or twin peak sign. Whereas, sorry, whereas the inverted T sign is what you see in the monochorionic diamniotic pregnancies.
Yes,
Okay,
ma'am.
so that is you will not see the triangular projection of placenta here. Inside,
Yes,
instead, you will see only the dividing membrane
yes,
reaching
ma'am.
the placenta at the right angles. You see the inverted T alone. So
Yes,
lambda or twin peak is for dichorionic diamniotic, whereas inverted T is for monochorionic diamniotic pregnancies.
yes, ma'am.
Okay. So what is a vanishing twin?
Ma'am, vanishing twin is vanishing twin is like they it dies, ma'am. The twin dies like our case, ma'am.
So
During the
initially you document two
twin and
pregnancies. Uh, Later date, one of it gets absorbed or one of it disappears. That is called vanishing twin. Your case is looking partly like a vanishing twin and it is
but
looking
the
partly
twin,
like a trap. Yeah,
yes, ma'am.
because you are still able to see the
Deliver the twin.
lower limbs and the rudimentary things in the
Yes, ma'am.
ultrasound, and you are also able to deliver a part of it, right?
Yes,
So, what
ma'am.
is fetus pathraceous?
Ma'am, fetus papillaceous, the fetal parts will not be developed completely, ma'am. But we can still deliver the fetus because it occurs due to the compression of the fetal parts, ma'am.
Mm. So it is partly like a vanishing twin, but it is not getting absorbed completely. Instead, it is just compressed by the
Yes,
growing
ma'am.
surviving twin. So in like in your case, you can see, feel or see the remnants of it during delivery.
Yes,
Okay.
ma'am.
So if your case was an ideal or a typical trap case, okay, like with the twin reversed arterial perfusion syndrome, wherein you have features of cardiac failure and hydrops fetalis and polyhydramnios in the pump twin, what will be the management for such a typical trap case?
For typical trap case, like if it is identified too early, we can suggest termination of pregnancy one. But if it is so much advanced time, we have to like form shunts. We have to stop the pump twin from perfusing the perfusion.
Okay, so you can try laser photocoagulation of the abnormal placental arterial communication.
Yes.
Okay, so either you can do an expectant management when there is no worsening symptoms of the pump twin, like in your case, or when there is evidence of worsening of the pump twin, you can try laser photocoagulation of the arterial communication, because that is what is the major pathology, right? That is what is
Yes.
causing the shunt of blood from the pump twin to the other perfused twin, which doesn't have a heart and which doesn't have a head. It only has the
Yes.
lower limbs, rudimentary lower limbs. Okay, so what is Quintero staging for twin to twin transfusion syndrome?
Madam
You
student.
don't you don't know. Okay. So
Mm,
coming to the other part of your case, the major presenting complaint was elevated blood pressure levels, right?
yes.
So what is the definition of gestational hypertension?
Gestational hypertension is increased blood pressure or having symptoms of increased blood pressure during the only during the pregnancy. That is after conception to the time of delivery.
Okay.
Only found
So
during
what?
pregnancy. She might not be an overt case of hypertension or previously known case of hypertension.
Okay. What is preeclampsia?
Preeclampsia is she's showing symptoms of high blood pressure, but her blood pressure has not raised to the mark.
Preeclampsia is when the gestational hypertension is presenting with proteinuria.
Yes,
Okay.
ma'am.
So, and when you say gestational hypertension, what you said is only a part of it. That is, it occurs during pregnancy and it resolves after pregnancy, gestational hypertension. But the whole definition includes a blood pressure of more than 140/90 in at least two separate occasions of 4 to 6 hours apart in a previously normotensive non-proteinuric women after 20 weeks of gestation, and
Yes,
this has
ma'am.
to go back to normal within 12 weeks of delivery. This is the
Yes.
whole definition of gestational hypertension.
Mm-hmm.
So, since your case is not a typical trap case, you have managed it only as a singleton pregnancy with just gestational hypertension,
Yes,
right?
ma'am.
But it still needed increased doses of labetalol for the
Yes,
blood
ma'am.
pressure to be under control. But still, it has not gone to the preeclampsia stage because there was no proteinuria. So, it was
Yes, ma'am.
only a gestational hypertension with an atypical trap. Okay.
Yes,
So
ma'am.
one more thing that I noticed in your presentation was that you mentioned that the NT scan findings, and you said that the crown rump length was 1.7 centimeter when
Yes,
the
ma'am.
NT was measured. So ideally, the criteria to measure nuchal translucency is for the CRL to be between 45 to 84 mm.
Yes,
Okay,
ma'am.
so I think that might have been a mistake on your part of interpreting the
Yeah.
ultrasound.
Yes.
So I would like you to go back and check it later.
Yeah,
So what is twin anemia polycythemia sequence?
ma'am, like the maternal blood is flowing to the pump twin, ma'am. From the pump twin, the perfused twin is getting the blood, ma'am. So initially,
Okay.
when the perfused twin receives the blood, the pump twin has chance of going into anemia, but other sorry, ma'am, the perfused twin has a chance of going into anemia, and the pump twin, due to receiving large amounts of blood from the maternal blood, it may go into polycythemia.
Okay.
It
So
is
in
due to
twin to
unequal
twin.
blood count.
Okay, so in twin to twin transfusion syndrome, you will see that one sac is having oligohydramnios, one sac is having polyhydramnios, one will have a growth restriction, the other will have increased growth or hydrops fetalis. Whereas in
Yes,
twin
ma'am.
anemia polycythemia sequence, you will not find any differences between the Leica levels or the
Mm,
growth. The difference will only be in the hematocrit and the HB levels. So that is the difference between twin to twin transfusion syndrome and twin anemia polycythemia sequence. So twin anemia polycythemia sequence is actually a minor variant of TTTS. You can put it that way. Okay. So these are the complications that are specific to a monochorionic monoamniotic pregnancy. So what are the maternal and fetal complications that you will see even in a dizygotic pregnancy? This is just to
Uh,
finish your discussion.
Ma'am, in dizygotic pregnancies, as a mother is harboring two children, they need more blood supply and nutrition, and hence, if the
Okay.
mother is not adequately supplied of blood, she may develop anemia with complications, ma'am.
Okay. Then
Then,
a twin pregnancy, the mother is more prone for anemia, gestational hypertension, gestational diabetes, and in early trimester she is more prone for hyperemesis, spontaneous
yes,
miscarriage, and in late trimester she is more prone for preterm labor, pressure symptoms, and fetal complications. There are more chances for congenital anomalies, discordant growths, and premature labor or prematurity, and more chances for intrauterine growth restriction. So these are
yes,
the
ma'am.
complications that you'll see in both dizygotic and monozygotic twin pregnancy. I think that's it, Birami. Thank you for the
Yes.
presentation.
Thank you, ma'am. Thank you. Thank you so much, ma'am, for your time in spite of your busy schedule and for your effort and patience. So that's all for today. We would like to thank everyone who made this event very possible. Hope you found that the event to be a valuable learning experience. So results will be announced shortly. We will meet you tomorrow with our other exciting events, Audentia BDS quiz and Corazon MBBS quiz. This is Pavitra signing off. Thanks again.